Good morning. I think we're just getting started and folks are just getting ready to join us. I want to give a really warm welcome to everyone that's joining us this morning. My name is Dr. Heidi Gray, and I will be joined by my co-host, Dr. Renata Urban, for this really incredible program we've put together focusing on uterine and endometrial cancers for patients and caregivers as part of our education program at the Fred Hutch Cancer Center, University of Washington. So I know, and just please, again, feel free to join and come in and out. Let me go to the next slide.
Sure. Good morning, everyone. We just want to start with a land acknowledgement that we think that at Fred Hutch and UW we think is really important. Fred Hutchinson Cancer Center acknowledges the Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Duwamish, Puyallup, Suquamish, Tulalip, and Muckleshoot nations. This is the land on which Fred Hutchinson and UW sit, and we're grateful for our ability to use this land. Next slide, please.
So just, sorry, can you go back to the other one? So just a brief, I'm, as I said, you're one of your co-hosts, Dr. Heidi Gray and Dr. Renata Urban. We're both GYN oncologists, so we specialize in women's cancer care at University of Washington and Fred Hutch. And we're going to be joined by an excellent group of panelists here today, this morning, to talk about all sorts of aspects regarding endometrial and uterine cancer.
We have a really great agenda for everyone this morning. Certainly we're grateful for the ability to do this digitally. So you can join and come back anytime, but we're starting out with a presentation actually from one of our fantastic fellows, Maya Gross. She is doing work with the Grace Center at the University of Washington and will be presenting on the symptoms and diagnosis of endometrial cancer. Next, Dr. Gray will be joining to talk about novel surgical approaches to endometrial cancer. We then have Dr. Isabel Rodriguez, who is one of our division members, talking about the molecular subtypes of endometrial cancer. Dr. Kalyan Banda, a medical oncologist in our division, will be presenting on precision medicine and treatments in endometrial cancer. And then I'll be concluding with a talk about health promotion and survivorship, both for endometrial cancer, but really for all gynecologic cancers. We'll have definitely time to address questions along the way, so please feel free to use the chat. And then we'll be wrapping up hopefully around noon.
Yeah, so a little bit of housekeeping, and I think we were just joined by Dr. Kalyan Banda. Good morning. He is a medical oncologist that specializes in GYN cancers at the Fred Hutch, really excited to listen to his talk this morning. This is a recorded talk, and it's virtual, obviously. And so if you do have to maybe if you're not able to kind of stay for the entire presentation, if you've registered, then you have access to all of the talks and you can look at them later. So please feel free to kind of come in and out if need be. We do have a chat function that you can post questions to. The questions aren't visible to the entire group, but we will be answering them online. And really, kind of focusing on questions that you might think the whole group might benefit. We kind of try to discourage kind of personal, questions maybe about your care. That's not our intent today, but we will be answering those questions live. And we'll definitely have time at the end of each talk to make sure we go through things. And then just a reminder, if you accidentally leave the Zoom webinar, you can just rejoin at any time if you need to. And then please, after the event, fill out the feedback form that you'll receive a link to. Okay. So I think our first speaker, Dr. Urban, has she joined?
Gross is joining.
Oh, she is.
Yes.
Okay. So let me introduce our first speaker. And then I think, Ritu, do you have the slides to put up?
I do have her slides, but I think she'll be sharing her own.
Okay.
Yeah.
All right. Okay. All right. We'll just give her a minute to join. So we're really excited to put together this program. This is our first time doing this for our group, and it's had a lot of success in other groups. And so we're really looking forward to putting on other disease site events as well too. And so this is really excited for this program.
We can answer this question. We got a question from one of our attendees. It's a great question. So can you share where I would find other events if I'm interested? Great question. And I may have Ritu join it just to also chime in, but the Fred Hutch website has a section for patient education and information and has opportunities to register for them. And then I actually have some information at the end of my talk, which again, if you're not able to stay for the end, I have some links to other resources within gynecologic oncology for patient education events. These are more national. And so the Fred Hutch website is the best one to go to from the point of view of Fred Hutch website, Fred Hutch specific events. Oh, thank you so much for providing that. Just as to let everyone know, we just had a link posted that has a link to all upcoming patient education events.
And that should be available in your chat function. So, sorry, we're just having a little technical issue getting our first speaker up and running. Just bear with us for a minute. I mean, alternatively, I could, oh, there we go. Okay, perfect. So, good morning. So we're just letting Dr. Gross join us. So we just kind of give a little overview. Let me introduce our first speaker. Very excited for her talk. Dr. Gross is a fellow at the University of Washington, Fred Hutch, and she is going to be talking to us today about symptoms and diagnoses of uterine and endometrial cancer. So nice warm welcome for her. So you're going to run your own slides, is that right? Okay, so you can go ahead, and I think you have access and you can share the screen. Welcome.
Thank you. Okay, sounds good. Let me just share my screen here. And I'm just going to go into presenter view. Okay, can you all see my screen here? Can everyone see
We're seeing your screen, but I think we're seeing the entire thing, Maya.
So I think you want to put it in presenter view. Yeah.
Yeah, okay. Oh, so sorry.
No worries.
And then, okay, hold on one second. Okay, is that better?
Perfect.
Okay.
That looks great.
Okay, sorry about that. Okay, good morning, everyone. Like Dr. Gray said, my name is Maya Gross. I'm a board certified OBGYN, and I'm currently receiving additional training here to become a gynecologic oncologist. I know this education forum is open to patients and caregivers for patients with gynecologic cancers. And so some of you may have experienced this process of symptom recognition, evaluation, and eventual diagnosis of endometrial cancer. Your personal experience makes you an expert in this topic, so feel free to chime in and add things if I miss anything, and feel free to ask questions at any time. And if you feel like this is repetitive for you and not informative because you know what we're talking about already, feel free to step away and take a break. This forum is for you all. So I first wanted to just kind of introduce where the information that I'm going to be talking about is coming from, or where some of it's coming from. At the University of Washington, I work with Dr. Kemi Dole, who's a gynecologic oncologist. She conducts full-time research and focuses on endometrial cancer research. She has a special focus on endometrial cancer in Black patients. Much of the information that we're going to talk about here were put together or created for research that we've been doing in Dr. Dole's lab. Dr. Dole's lab recently created an educational resource that you can see over here called Guides by Us that incorporates input from patients to spread reliable information about endometrial cancer, symptoms, diagnosis, a lot of the stuff we're going to be talking about today. You can access this on the internet or on social media platforms. So please utilize this resource whenever you want to, share it with your friends and family. One of the main points of this is that by educating our communities, we can create big changes. So today I'm here to talk about first what endometrial cancer is and what uterine cancer is. So we're going to talk a little bit about anatomy and terminology. We're going to talk about common symptoms of endometrial cancer and less common symptoms. And then we're going to talk about which steps are available to evaluate people with symptoms concerning for endometrial cancer and talk about how endometrial cancer is diagnosed. I want to quickly root us in normal anatomy. On the right side of this screen, I have documented normal parts of the uterus, cervix, and vagina. So we have the myometrium, which is the muscle layer of the uterus. We have the uterus as a whole is this large blue square here. And then we have the endometrium, which is the lining of the uterus. That's the layer that grows and sheds with the menstrual cycle each month. The cervix is attached to the uterus and is the organ that usually is closed. It's sort of a fibrous muscular tube, and it opens a little bit during the menstrual period to let the endometrial lining and blood out, also opens during labor. And then we have the vagina here. Part of what I've realized in this career and doing research so far, talking with family and friends, is that a lot of people don't really know these different parts of their own reproductive anatomy. So sometimes it can be confusing talking about things down the line. So I just want to make sure we're all on the same page. I then wanted to describe the two types of uterine cancer. There's two main areas that uterine cancer can start in. So over on the left here, we have endometrial cancer. That is cancer that starts in that lining of the uterus. So you can see it sort of involves this thinner layer here. It can grow and spread other areas. So it can grow into the muscle of the uterus and could grow into the cervix, but it's cancer that starts here. On this other side, I have a picture of a uterine sarcoma, which is a cancer that starts in the muscle layer of the uterus. Carcinomas or endometrial cancers make up more than 95% of all uterine cancers, and sarcomas make up less than 5%. So today we're going to be focusing mostly on symptoms of endometrial cancer or carcinoma, but we'll use the term uterine and endometrial cancer interchangeably, as uterine cancer kind of encompasses both of these two things. There are also different types of endometrial cancer, which we aren't going to cover today, but some of you may be familiar with that. We also aren't going to be talking about different types of gynecologic cancers, like cancers starting in the cervix or cancer starting in the vagina, ovary, or fallopian tube. Next, I want to talk about some symptoms of endometrial cancer. First, I want to start by watching this video with you all, created by the Spot Her for EC campaign, which is another campaign that focuses on patient education. And so this is another thing that you can access their website, get information, and also share with friends and family.
If this was yesterday, maybe small moments would have slipped by, and the signs of endometrial cancer would have been dismissed. Maybe spotting was overlooked. Just something that happened on girls' night out. Maybe unusual cramps were written off as an off point when otherwise good week. Maybe yesterday, losing weight without trying went unmentioned or even unnoticed. But this isn't yesterday. This is today. And today marks the end of silence around one of the most common yet under-recognized women's cancers. In the past, women with endometrial cancer have felt their symptoms were often stigmatized or dismissed. But by speaking up about these below-the-belt symptoms, we can empower her to spot the signs early and take action when it's most treatable. Some common symptoms may include abnormal bleeding, spotting, or brownish discharge after menopause, as well as irregular or heavy bleeding in women before menopause. Symptoms of endometrial cancer can include pelvic pain or feeling a mass, and even losing weight without trying. It's time to end the stigma and start the conversation. Let's listen. Let's advocate. Let's put her health first. Join us in our pledge to spot her for EC and raise our voices around this serious cancer for the women we love and the women we are.
Okay. So that video went over, sort of briefly touched on many of the symptoms that happen or can happen with uterine cancer and endometrial cancer. But I kind of wanted to talk about it break it up into early symptoms and later symptoms. And that's kind of the way that we usually think about them. The way that symptoms of early endometrial cancer are usually described, it depends on where patients are in their menstrual lifespan, specifically whether patients are premenopausal, perimenopause, so starting to have changes in their menstrual cycle, maybe starting to have menopausal symptoms, but not all the way through menopause, or whether patients are postmenopause, which is defined as going a full year without having any bleeding. So 12 months from your last period. I want to acknowledge something that we hear from patients who have uterine cancer, which is that sometimes patients say they never stopped bleeding or never stopped having periods. And so sometimes that definition of being postmenopausal can be confusing or not be clear for some patients. So when patients are postmenopausal, any bleeding, any spotting is abnormal. And that bleeding or spotting can be heavy bleeding like a period. It can be really small volume bleeding. And sometimes it doesn't even look like blood. Sometimes it looks like brown, black, or gray discharge. And anything like that is something that's abnormal that should definitely be evaluated. In the perimenopause and premenopausal periods, the symptoms are similar. So bleeding in between your cycles, so spotting in between. Sometimes patients can have bleeding during sex. Sometimes patients just have really heavy bleeding during their period that's different for them or different than normal. And then abnormal discharge as well. There are symptoms of uterine cancer that usually present when the cancer is growing more or is more advanced. However, it's important to know that some people experience these symptoms when they still have early stage disease. And so symptoms alone don't tell us how far the cancer has spread. And many patients don't experience all of these. They might just experience some. So one is pelvic pain. That can be cramping, like menstrual cramps or sharp pains that come and go. Some patients will experience bloating or changes to bowel or bladder habits like diarrhea or constipation, urinating more frequently. Some patients experience fatigue and exhaustion that can be related to the cancer itself, or sometimes that can be related to having heavy bleeding and potentially being anemic from that. And some patients can experience unexplained weight loss. And then finally, at any time during the endometrial cancer experience, patients can continue to have abnormal vaginal discharge and bleeding. Although I do want to note that there's a very small group of patients that actually never have abnormal bleeding. Next, I want to move on to talk about evaluation and diagnosis of endometrial cancer. First, we're going to just kind of talk about what some of the acceptable pathways are for evaluation of potential endometrial cancer. So this starts when patients notice symptoms, they notice something different at home. And then typically you would present to any doctor. That can be your primary care doctor, emergency medicine physician, an OBGYN, women's health provider. And when you report the symptoms, that doctor will take a full history, ask you a bunch of questions, do an exam, a pelvic exam, to see if there's any masses or anything that they can see on exam. And then when you're postmenopausal, there's a couple options that are acceptable and both approved and endorsed by our governing body, which is known as ACOG. One of them is to do a pelvic ultrasound to evaluate the uterus, the lining of the uterus, and see if there's any abnormalities. And if that's normal and patients have only had one episode of bleeding and that bleeding has resolved, then sometimes it's appropriate to have patients kind of stop the diagnostic pathway at that point. And then if they have more symptoms or their symptoms recur, to come back. If that pelvic ultrasound is abnormal, so often what that means is the lining of the uterus, the endometrium, is thickened from what we would expect, then the recommendation is to do tissue sampling, and that it can be a couple different types, and we'll talk about that in a second. That tissue sampling will be a biopsy of the endometrium and will give us more information about the actual tissue and what's going on. The other option when patients present with symptoms is to just go directly to tissue sampling and start with that. And then I want to talk a little bit about kind of pros and cons of each of these methods and the type of information that they give us. So this first option, the pelvic ultrasound, many of you may have had one of these before. The advantages to this are it's less invasive, so it doesn't involve a biopsy or taking any tissue from the body. The ultrasound can show us what's going on with the uterus, so it can show structural changes like fibroids, a polyp, or other masses, in addition to showing that lining of the uterus. And then the ultrasound is also relatively less uncomfortable than a biopsy because we're not taking a sample of tissue. I will say we hear a lot from patients that it's not that pelvic ultrasounds are comfortable. Often there's a lot of pressure, and for some patients they can be kind of painful, but that's kind of the advantages. They're less pain than a biopsy. Disadvantages are that the ultrasound is not a diagnostic test. So because we need a tissue sample to diagnose cancer, and the ultrasound doesn't give us one, ultrasound is never going to be the final step unless it's completely normal and your symptoms never come back. Additionally, there's been recent information that has shown us that ultrasound is actually not as accurate or not as sensitive in detecting cancer in patients that are high risk for cancer. Specifically in Black patients, it's been shown to be less sensitive. And then in certain types of higher risk cancer, it's also not as sensitive as a biopsy. So it's not always an appropriate step for people, or might not be the only step that we often would do something in addition. The next option is an endometrial biopsy, which some of you also may have had. This is something that we do in the office. So the endometrial biopsy is when you're in the office and the provider uses a speculum, which is this metal tool, to see the cervix, and then they insert this very small, we call it a pipelle. It's a little suction device that just goes inside the uterine lining and removes some cells from the inside of the uterine lining. And then that tissue is sent to the pathology department to evaluate it and look for precancer, polyps, or cancer. Advantage of this is that we can get a diagnosis in one step if it's abnormal. Sometimes it's normal and we don't get an answer from that. It's more sensitive than ultrasound, so it picks up more often a cancer or a precancer. And this can be done in the office. And there's options for pain management to be done in addition to the endometrial biopsy when you're in the office to make it more uncomfortable. The disadvantages are that it is more uncomfortable or painful compared to an ultrasound. And sometimes we actually can't get the tissue when we're trying to do this in the office. Sometimes the cervix, especially after menopause, can become more closed. It can have some scarring or be stenotic, which basically just means it's kind of hard and closed. And endometrial biopsies also are uncomfortable. And so for some patients, they're too uncomfortable to be done in the office, although for most patients they can be. And then the final kind of disadvantage to a biopsy is true for any time we do a biopsy or take a tissue sample from anywhere in the body. And there's risks associated with doing that. For this procedure and for the next one that we're going to talk about, those risks are very, very low. And overall, this is a really safe procedure. But anytime we do a biopsy, there's risks associated with that, like a small risk of bleeding, small risk of infection, and then small risk of damage to other structures near the endometrium where we're trying to take the biopsy. The last option that we're going to talk about that can be sometimes in this initial diagnostic pathway is called a dilation and curettage. This is another method of getting tissue sampling. The advantages of this is that this is the most accurate test. It can obtain more tissue than the endometrial biopsy can. So the way that we do this is typically in the operating room, although some people are able to do this in the office. But we are in the operating room. We again use the speculum. And then this doctor here is looking through a camera to see inside the uterus, and that's called a hysteroscopy. That can be combined with that dilation and curettage, but isn't always. And we are able to kind of obtain a sample of tissue from all the way around the inside of the uterus. The disadvantage of this is that usually this does need to be done in the operating room with sedation or anesthesia, and so there's cost associated with that. And risks associated with the procedure, like we just talked about. These 3 tests in some combination will help us eventually get to a diagnosis. So that may be a normal uterus, a polyp, a precancer, or a cancer. Does anyone have any questions about these diagnostic tests before we move on? Okay. So what do we do if all the tests are normal? If all your tests are normal and symptoms are resolved, so they are not happening anymore, then we have you watch for new, different, or recurring symptoms at home and say to please come back. What we've learned from endometrial cancer research is that sometimes patients get reassured by their doctor in the office about symptoms that they're having. And then when those symptoms come back, they remember that reassurance and don't necessarily re-present to the doctor. So anytime something new or different changes, we always want to see you again, because that initial normal test doesn't mean that something won't change in the future. And then finally, I just wanted to quickly go over the steps of just what happens after endometrial cancer diagnosis. So after your doctor diagnoses a cancer, they refer you to a gynecologic oncologist like Dr. Rodriguez, Dr. Gray, and Dr. Urban. These are specialists in female reproductive cancer care. Those doctors will either recommend doing surgery right away or getting extra imaging like a CT scan, and sometimes getting extra testing of the tumor. And that will give us information about stage, so how far that cancer has spread, as well as what type of cancer it is. And then that information will allow us to give final treatment recommendations, which may include chemotherapy, may include radiation, might include not doing additional treatment, and might include targeted therapy. And you're going to get to hear a little bit about that later. That's all I had for you all. Does anyone have any questions for me?
Yeah, thank you, Dr. Gross. That was really an excellent overview. I know some people are putting some questions in the chat, but there was a couple things I wanted to ask that I get asked a lot. The first is, can this be picked up by pap smears or pap tests? Is that a way to diagnose endometrial cancer?
Yeah, that's a great question. So pap tests cannot diagnose endometrial cancer. However, sometimes an abnormal pap test can be a signal that there might be something wrong with the cells higher in the uterus. So the pap test is meant to look at the outside of the cervix, and then a little bit into the inside, but it's meant to be looking at the cervical tissue. But sometimes there can be some results in there that just tell us something isn't quite right, and we're getting cells that look a little different that then trigger us to do some of this evaluation. But the pap smear on its own can't diagnose the cancer.
Great. Yeah, and I think, some patients will say like, well, I've had pap smears my whole life and they've been normal. Yeah. How did this happen? How was that missed? And as you brought up that many times, although sometimes the pap will show up as abnormal as kind of a signal that maybe something's going on.
But often it doesn't. Yeah.
If it doesn't, but if you do show up with an abnormal pap test, please, make sure you really talk to your provider about what that does or doesn't mean and what specifically the follow-up. for patients who've undergone menopause and have an abnormal pap smear, they many times do need one of these biopsies or something to determine, to make sure that abnormal pap smear isn't from the uterus. So excellent point about that.
Yeah.
Maya.
There's a couple questions in the chat that I'm happy to address. So the first person said, the pelvic ultrasound for me only showed ovarian cysts, not a thickened lining. And I was premenopause. So the standard of care was not to do a biopsy. Is that changing? Like, is the standard of care changing? So great question. And I'm sorry that that happened to you. That's really frustrating when you feel like the diagnostic process doesn't work well for you. So we do know that like I was talking about, that ultrasound sometimes doesn't show a thickened lining, and that happens more in certain types of cancers, but it can also happen in normal endometrial cancer. So there's a small chance that that can happen. And it sounds like you said you were premenopause. The premenopausal period also we're finding out for doctors is a little more tricky, because patients do have abnormal bleeding throughout their menstrual life cycle, if that was a symptom for you. And so sometimes for doctors, knowing when to do that biopsy is a little more tricky for them. I think the standard of care may change. Especially in the postmenopausal period, we may end up relying more on biopsies and relying less on ultrasound. Right now, if you get an ultrasound that shows that a cyst and doesn't show a thickened lining, then the standard of care wouldn't be to do a biopsy right at that time. However, if you were having symptoms that kept happening, then often we would do a biopsy, even if the ultrasound isn't normal. But that's definitely, I have definitely heard that from patients, that is a part of that diagnostic process for them. And then the next person said, you didn't put hysterectomy as the treatment. That is very true. So let me see if I can just share quick.
The next talk, so I'll be talking about surgery. So we'll be addressing kind of specifically surgery as a treatment, and then other speakers will be talking about other treatments. And so we'll have some opportunity there. I just wanted to, again, follow up on what Dr. Gross was saying, that, I think we're really trying to push information out there to general practitioners and primary care physicians about kind of, when to kind of work things up sooner, because I think a lot of times patients' menstrual cycles or their history can be very abnormal through their earlier years. And so there's some normalization or thought that, oh, that's just how my periods have always been. But as women age and patients age, that when still having kind of either heavy bleeding or irregular bleeding, particularly after the age of 35, that again, most of the time that's not due to cancer, thank goodness, but there are a lot of other conditions that can cause it. For example, polyps, which are benign, or fibroids or things. And so definitely kind of getting the next level of either biopsy, or, as Dr. Gross had talked about, that hysteroscopy, which can go ahead and remove a polyp if it's abnormal. So we're hoping to really kind of push the message out, not to just focus on women who've stopped having periods, or patients have stopped having periods and then in the menopause, but in that kind of perimenopause, getting sooner workup.
Yeah. And then just to clarify a little bit, I should have written hysterectomy here, but usually when we do surgery for endometrial cancer, what that is the hysterectomy. So in my head, that was clear, but it obviously isn't. So I'm sorry about that. But yeah, usually that would occur here, and then that would tell us the stage and spread. And I'll let Dr. Gray go into that more. Do I have time to do a couple more questions, or do
I
we
think
want?
there was a couple of questions. One was kind of looking at, are there others like biomarkers, or I think blood tests to screen for early cancer? So I'll let Dr. Grosick that one. And then the other one, if I think we should have time for it, is kind of talking about a little bit of hormones and risk.
Okay. I'm just going to read this quickly. Are there any screening tests in the work, such as biomarkers for endometrial cancer and screening ultrasounds? Yeah. So unfortunately, for endometrial cancer, there aren't really any screening tests. And obviously, Dr. Gray and Dr. Urban will jump in if they have anything to add. There aren't any screening tests for endometrial cancer right now. The test that often is used in ovarian cancer once patients have cancer, the CA-125 test, even that isn't a screening test for ovarian cancer because it won't show us kind of in those early stages. And in terms of screening pelvic ultrasounds, that has definitely been thought about whether that would make sense to do or whether that would be a good option. And it turns out that it just doesn't efficiently kind of find these cancers. And often it finds ultrasound, if you did it with everyone, often it would find a bunch of abnormal things because the uterus and the endometrium are different in everyone. So often if we just did it for everyone, it would find a bunch of abnormal things in patients that were healthy and that didn't have any symptoms. And then it leads to extra biopsies, potentially surgeries, treatments for people that maybe don't need those things. And so it turns out the risk benefit of doing ultrasounds for everyone isn't beneficial for patients.
For that instrument, I think about screening ultrasounds is that we actually might miss a lot of cancers. So I think Dr. Gross mentioned that ultrasounds have been found to be less reliable at detecting cancers in patients with fibroids, which is for ultrasound. In addition, some forms of endometrial cancer actually don't show up as a thickened lining. And so even if we were to use ultrasounds, we may still miss some endometrial cancers. There's certainly a lot of ongoing studies as to more accurate means of looking for endometrial cancers that might be either as invasive but less invasive than the ultrasound. So I think there's a lot of work still being done, but not being commercially available yet. And there's one more question I'll go ahead and note it here. So there was a question about someone who had some postmenopausal spotting and then was started on hormonal therapy to reduce vaginal discomfort. And that's a good question because certainly, after menopause, setting of the vagina can be really uncomfortable, can certainly affect daily life and sexual function. The hard thing is that vaginal estrogen is definitely a solution to that, but it can certainly also impact the uterus. So I think the short answer to that question is, did the hormonal cream possibly increase the growth, leading to a diagnosis of endometrial cancer is possibly, but we don't know for sure. It's certainly possible.
But overall, a vaginal hormone cream is really safe. And the amount of hormone that gets absorbed into the body when you use it just in the vagina is really, really minimal. And so, correct me if I'm wrong, but I don't think that vaginal estrogen cream is associated with a risk for endometrial cancer.
And I think this is a really important kind of topic, and maybe we can carve out time in one of the other, because I think there's a lot of interest in kind of the hormonal, what's the relationship between hormones and these cancers. I'm not sure if any of us have kind of addressed that in any of our lectures, or any of our talks, but we'll make sure we carve out some time to address that, because I think we want to have a little bit bigger discussion maybe about some of that. Right? Does that sound okay for the panelists? I do want to be mindful to kind of keep on time. But I really appreciate your talk, Dr. Gross. That was excellent. And please keep the questions coming and we'll try to answer them. And if we can't get to all of them, we can, try to also answer them in another format. Okay. So I am now going to switch gears a little bit and talk about kind of one of our primary therapeutic options, which is surgery in endometrial cancer. And I use the terms endometrial cancer and uterine cancer a little bit interchangeably. My apologies. As you heard from Dr. Gross, the vast majority of uterine cancers are endometrial cancer from the lining, but I want to include, there are the uterine sarcoma patients that also fall into a lot of these categories, but I'll slip back and forth between the two. Okay, I am going to share my screen. Give me 1 minute here. And let me just go to my, 1 second. Can people see my slides?
We can now see your notes. Yeah,
Okay,
now
how
that
about
looks
now?
perfect.
Now
Yep.
we're good? Okay,
Yes.
perfect. Yeah, I just had to switch. Okay, again, I just wanted to thank everyone for being present and your questions. I'm going to be talking about our surgical approaches to endometrial or uterine cancer. As a GYN oncologist, we're a little bit different than other disease specialties where we actually take care of both the surgical side of management of GYN cancers, but we also manage our patients through their therapeutic sides with either chemotherapy, immunotherapy, that type of thing. So you're going to hear from both sides of this, but at the heart, all of us are surgeons. So just briefly, again, there's really kind of 4 categories you can think about for all generic cancer treatment: surgery, radiation therapy, which we are not addressing specifically today, but can be used in another format. Chemotherapy, which has been a mainstay of adjuvant treatment, and then targeted therapy and personalized medicine, which Dr. Banda is going to introduce us to in a minute. And then, so I'm going to be focusing on surgery. So just briefly, this isn't, I love talking about surgery. I love doing surgery. It's my favorite day of the week. And I'm just going to kind of give an overview just to also let folks know I'm not going to be showing any videos, surgical videos. I don't know that I have your permission to do that. And I know for some folks that really isn't something that they want to be exposed to. So I'm happy though, if people are interested in surgical videos, I'm happy to share some sites for that. But just to let people know, I'm not going to be showing any of that, if that's just so it doesn't have any trauma or anything associated with that. But just a brief, very brief history of surgery. This is in like 2 seconds or less. But really before the 1900s, there was really very poor outcomes for surgery. And really, we had to develop appropriate anesthesia and antisepsis models to prevent harm to patients. And so that really didn't happen until the 1800s. And then interestingly, we're almost on the 200-year mark of the first vaginal hysterectomy. It was in 1828, which just is kind of blows my mind a little bit. And then in 1848 was the first abdominal hysterectomy. But even then, surgical outcomes were pretty tough because we really hadn't developed the appropriate kind of antisepsis and care of patients, and also availability of blood products also was fairly limited. So in the early 1900s, of course, penicillin was discovered, and that really was a game changer for almost every aspect of medicine in terms of like care of patients. So really the development of kind of modern surgery happened in the mid 1900s with all the specialties where we could actually not care for disease, but also get patients safely through a postoperative period. The next kind of area, and I'm going to focus on this, has really been the rise of minimally invasive surgery to help improve patient outcomes. And then in the 2000s has been the development of robotic surgery, and I'm going to talk a fair amount about that. And then other areas, not just the kind of technical aspects of surgery, but we've also enhanced our patient recovery and our care of patients during surgery using surgical checklists, and I'll talk a little bit about that. And then also in using our enhanced recovery after surgery protocols, which again have had important impacts on patients' care and recovery from surgery afterwards. And these are just some drawings of like how far we've come in the last 200 years. So endometrial cancer is the most common gynecologic cancer, about 67,000 cases per year in the United States. As you heard from Dr. Gross, most folks present as early stage, meaning it's confined to the uterus itself. This is a drawing, again, sorry, I'll use this screen. This is a drawing again of the uterus, the cervix, the fallopian tubes, and the ovaries. And this is that picture drawing of that pipelle that can use to sample, okay? And again, usually for most patients, surgery is the first line treatment for this cancer. Oops. This is a kind of overview of kind of the different options for cancer surgery for endometrial or uterine cancer. First is what we call a complete hysterectomy. And what that really entails is removing, this is a drawing, this is actually what a real uterus looks like, not just a cartoon. And this is the body of the uterus and the cervix. And you can see they're kind of all as one. They're not two separate organs. They're really just, the cervix is the bottom part of the uterus that then is attached to the vagina. And then you can see the fallopian tubes come out here, and then these little white areas are the ovaries. And so at minimum, a complete hysterectomy is for uterine cancer, endometrial cancer, is removing the uterus and the cervix. And then for the vast majority, particularly in folks who are after menopause, is removing the fallopian tubes and the ovaries themselves. We do think that the vast majority of these cancers are estrogen driven. And so there is precedent to remove the ovaries at the same time at the time of the hysterectomy. There can be unique circumstances in younger age folks or that maybe have either pre-invasive or pre-cancer or hyperplasia, where ovary preservation could be a possibility, and that's an individual discussion with your surgeon and your oncologist. But for the vast majority, it is recommended to remove the fallopian tubes in the ovaries. What are other options besides a complete hysterectomy? For folks who potentially may have very high risks with surgery, we call kind of a poor surgical candidate, there is kind of a less definitive option called a dilation and curettage, or a DNC, where we scrape out the lining of the uterus and then put in a hormone-laden IUD, intrauterine device, that has progestin that can kind of treat that cancer. It can also be an option for younger folks who maybe are trying to preserve fertility as a possibility. It can be successful in getting rid of the cancer, but age and some other factors, sometimes it can be not as successful in getting fully treating the cancer. But that is, again, an option, a specific option that could be possible. And then the last area that we do as part of surgery for endometrial uterine cancer is evaluating the lymph nodes. And so kind of for most we call solid cancers, so things like breast cancer, head and neck cancers, cancer kind of starts in its primary organ, and then it has a risk of spread, and that spread is called metastasis. And we always are trying to evaluate, where the cancer started and where it has gone to, and that's that term staging, which is an evaluation of where the cancer has gone to. And part of staging can be by radiographic, so CT scans, things like that. But then actually during surgery, evaluating other areas that the cancer might have spread to. And for endometrial cancer, the most common next site of spread is the lymph nodes. The lymph nodes are all over your body. They're all connected to one another. But for uterine cancer, they're in the pelvis. And we have these tools to evaluate lymph nodes, and I'll talk more about this a little bit later on. I'm just going to be mindful of time, about evaluating, not just removing all of the lymph nodes, but evaluating what we call the sentinel lymph nodes. Moving on there. So what are the types of hysterectomy? So kind of back in the, as I said, the rise of surgery, the open hysterectomy, which means a traditional abdominal hysterectomy, was kind of the standard of care for many, many, many years. And what that looks like, and many of you on the call may have had these surgeries, where you do an incision either up and down below the belly button, or kind of sideways, which is kind of also folks have had for a C-section. And you remove the whole uterus, the tubes and ovaries, and then the lymph nodes through that incision. The downside is that because it's an open surgery, requires a stay in the hospital. Recovery generally is about 4 to 6 weeks. So, a substantial time either off from work or from other kind of duties. Has pretty moderate rates of skin infections, as you can imagine. The bigger the incision on the skin, the higher risk you can have of skin infections. And of course, there can be more scarring. But it's for some folks, maybe if the uterus is very large or there's some factors, it's still a very standard treatment. But we really wanted to say, well, could we do the same surgery but in a less invasive way? And so as I alluded to, there's been the rise of minimally invasive surgery. You'll hear the term MIS. Really was in kind of the 1980s, 1990s. And what that concept was, that rather than doing a big incision, putting surgical hands-ins and retractors, could we make small incisions and use instruments, small little instruments, to do the same work? And so what laparoscopy is basically has 4 different components. One is a scope, which is an actual kind of tube that you can look into, okay, and that's up here. A camera, so that's attached to the scope, so you can see it on the video screen. A light source, because you have to be able to see what you're operating, and then we call a distension medium, so that you can see your operating field. And for laparoscopy, what that is typically carbon dioxide, okay? The benefit of minimally invasive surgery are these very small incisions, anywhere from like 3 to 5 less than a centimeter incisions on the abdomen. And as you can imagine, if the smaller the incision, the less painful it is, less risk of bleeding, less risk of infections, I think I already said. And then people recover much quicker, okay? So that was really an important, and really all aspects of most surgeries have adopted minimally invasive techniques. And so there are a variety of different kind of minimally invasive techniques. The original minimally invasive, what's called a total vaginal hysterectomy, which is when there's no incisions on the abdomen at all, everything's removed through the vagina. The downside of that is that it sometimes is, as you can imagine, it's hard to technically do for some folks, but also there's very limited ways you can't evaluate the lymph nodes. And so that usually is an important part of surgery as well. So laparoscopic hysterectomy allows, and you can see these little diagrams here, usually is 4 incisions. And that was kind of the initial minimally invasive surgery where you go with the camera and then the instruments go in and you use the instruments to do the whole procedure. And then usually the specimens are all removed, the uterus, all of that are through the vagina. And you're also able to evaluate lymph nodes in that setting. The next kind of generation that I'll also speak about is the robotic assisted hysterectomy. And those incisions look a little different because the way the robot is set up, and I'm going to show you some pictures about that. So most importantly, when we adopted, we were like, well, this is a great technology. We, can reduce pain, bleeding, infection, all these really important things, but does it give the same cancer outcomes, right? Before you adopt a new form of treatment, you need to make sure that if you're not going to compromise patients' care or their oncologic outcomes. So there actually, we did this study, it would be hard to do nowadays in today's environment, but we did a very large clinical trial back in the kind of late 1990s, around the 2000s, and said, okay, patients with endometrial cancer, we're going to look and see if we do laparoscopy, laparoscopic hysterectomy, or open hysterectomy, and then follow them and make sure that we're not seeing like worse outcomes in folks who got the minimally invasive surgery. And it actually showed that there were no survival differences, which was incredibly important. And of course, as we knew we would see, there's less surgical complications with minimally invasive surgery. And so really that became the gold standard and is the gold standard for the vast majority of patients are able to have a minimally invasive surgery, hysterectomy, to treat their endometrial cancer. So what was kind of the next leap? Well, there's some limitations about laparoscopy, just in terms of the instruments and visibility. And so in kind of the, I'd say kind of the early 2000s was been the development of robotics in surgery. And this is actually what the robot looks like. And so this is the patient here. And so similar to laparoscopy, the concept is the same. There's these small little instruments that go through ports. And then these are these instruments that are attached to this robot. And then the surgeon is able to manipulate the robot at a remote site. And I'm going to show you some pictures about that. So it's, again, the same concept of minimally invasive or as laparoscopic surgery, small incisions on the abdomen with these instruments going through. But rather than the surgeon at the bedside moving these little instruments, the robot is able to move the instruments, and it's not just, and you're able to use the instruments are highly specialized and can mimic your wristing of like as a surgeon. So you're able to do very delicate, complicated surgeries through these, the finessed movements of the robot. What also changed is the ability to kind of immerse yourself in a 3D view of the camera. And so that kind of, if anyone's like done virtual reality or any like where you have your eyes and all of that immersed in there, it really changes your brain's viewpoint of the surgery. And so that was a huge leap as well. And also you're able to do the other benefit of robotic surgery over minimally invasive surgery. Actually, I think I have my next slide on that down there, is you're able to do in patients that maybe weren't as good of candidates for laparoscopic surgery, maybe had more adhesions, things like that. The robot enables you to do those more complicated surgeries, keeping an eye on the time here. So this is a view of what the this is what the robot setup looks like. We use the most common robot, and just to be clear, I don't have any stock or anything in Da Vinci or Intuitive or anything. I'm not a spokesperson for them at all. The most common surgical robot is the Intuitive Da Vinci robot. There are other companies that do make robots, but as you can imagine, once you invest in one set, that's kind of what your most surgical centers are. But there's really two now that are being used. The one that we've used for a long time is the Da Vinci Xi, and this is what's called the console. That's where the surgeon sits, and I'm going to show some other pictures. This is the tower where folks in the room can see what's going on, and where all your electrical sources are set up to. And then this is the actual robot itself. The next generation that's being rolled out is the Da Vinci 5, which we have here at University of Washington. It's the same concept. The robot's just a little bit different size-wise. The console, the surgeon console, is also a little slightly different and just has some other features. And so again, just looking at how does this look like in the operating room? So again, the robot is at the bedside. This is the robot attached to the instruments on the patient's abdomen. And that's what the ports look like. Sorry, these pictures are a little fuzzy. This is the console that we sit at as a surgeon, where we put our face in the stereo viewer. We have these controls I'll show you. And then we also have these little foot pedals that we manipulate to help do energy sources and moving instruments. And so what this looks like is, here's a surgeon sitting at the console, and you can see this immersive experience, and then her hands are in the controls, and you can see there's these little finger controls, and you basically operate like you normally would, and that's translated to the robot. Whoops. So what that looks like in the operating room is, here's the surgeon where we sit at the console. There's a bedside assistant who is right next to near the robot. And then here, this is the anesthesiologist with the patient. Okay. So what's the benefit of a robot versus traditional laparoscopy? Well, as I talked about, it has better precision. Your visualization is better. You can perform more delicate and complex procedures, and you have less limited body habitus, particularly in patients with higher rates of skin wall, because you can overcome that better with the robot. The cons, the downsides is that is a higher skill set and training. As you can imagine, it's just takes a little bit more training to obviously use these equipment, both the surgeon and the staff. The cost of equipment is more expensive. It takes a little bit longer setup time, and it does require patients to be in this pretty kind of significant head down position. And so for some folks, if they have breathing issues or things like that, sometimes they can't tolerate that. I'm just going to keep an eye on the time. I have 10 more minutes, I believe, right? So I'll wrap up a little bit though, because I want to have time for notes. I think I started a little late. So so what other aspects of surgery? So just to kind of bring up that we also, for the longest time, did kind of these traditional, very lengthy removal of lymph nodes in the area called lymphadenectomy. And as you can imagine, the more lymph nodes you remove, the more swelling you can potentially have in the extremities, either in the arms if it's breast cancer, or legs if it's uterine cancer. So really, breast and melanoma patients really adopted this technology. And the concept of sentinel lymph node is that instead of removing all of these lymph nodes and testing to see if there's spread, could we test the closest draining lymph node to the organ, called the sentinel lymph node, biopsy that, and if that's clear, then the chance of there being spread to other lymph nodes is very, very low. So that, and that has been proven both in breast and melanoma patients, but also in uterine and endometrial cancer patients. And so the concept is that we inject, before we do the hysterectomy, we inject a dye into the cervix, and then that dye is taken up to the closest draining lymph nodes. There's usually one or two on each side of we call the pelvis. And we remove those. You can see them. This is oops, sorry, I have my pointer on the wrong thing. This is what it looks like, the dye taken up in the lymph node. And then as a surgeon, we can go in and just take out that one or two lymph nodes, test it. And if it's clear of cancer, then you don't need all of the other lymph nodes removed. I'm gonna move again. I don't have the chat up, so I'm going to do questions at the end, but please, my colleagues, if there's something, you can interrupt me if there's something I need to address immediately. So what else have we been doing to help improve surgical outcomes? So not just the technical aspects of the surgery, which is really has been incredible, but we also have adopted surgical checklists. So and this was really came from the airline industry, actually Boeing. So in the like 1940s, 1950s, there were all these like, airline crashes due to, and actually in the 70s, due to pilot error, not, the flaps weren't down, this wasn't up. And so they really developed, I think it was actually Boeing that developed this like pilot pre-flight checklist to make sure everything was done appropriately, because human error is everywhere. I mean, we that's you can't rely on just a human, surgeons or pilots just to remember everything. And so this really was true in medicine. So kind of in the late 1990s, there was a very big report from the Institute of Medicine that showed that there were really a lot of the poor outcomes patients were having were due to human error. Just not that your doctor was trying to do the wrong thing or didn't know, but just there wasn't systems put in place to make sure that all of the right things were done at the right time. And so the World Health Organization actually developed, particularly in surgery, this the concept of surgical checklist. And it's very similar to like what the pilot does at the right before the surgery, where you have a pause beforehand, the surgeon, the anesthesiologist, the nursing team, and you go through kind of what is the surgery. I'm going to actually bring up some of the things. So you review, is this the right patient name, date of birth, all of that. What is the actual surgery? Is there a site or side? In our world, we don't do so much situs, but you can imagine like kidney surgery or things like that. It's very important to know which side is being removed. What are the patient's allergies? Which antibiotics are going to be administered? How are we going to prevent blood clots? What's the patient's blood sugar, glucose, what instruments? So, and we go through this both before the procedure, before the actual incision. So we kind of do a 2-level, and then also at the end, we do a timeout with everyone in the room. So everyone knows what the surgery was, what happened in the surgery, what the specimens are. And this has really dramatically improved patient outcomes in terms of problems with surgery or having things not be missed in surgery. And so one of the other areas that we wanted to improve upon is a lot of things in surgery were kind of being done just because we did them for a long time, not necessarily based on knowing that if it was really helping patients. And so again, in the kind of early, I'd probably say like the, kind of mid 2000s, kind of 2010, there was a lot of interest in kind of saying, well, what else can we be doing kind of in the perioperative period to improve patient outcomes? Okay. And so we really instituted, and I was instrumental in instituting our enhanced recovery after surgery protocols for our group. And there's 3 different parts. One is before surgery, and a lot of that is really patient education. We needed to spend more time kind of talking with patients about what to expect with surgery, what to expect after surgery, what are things going to look like, what's the pain management going to be, all of that. We also realized that we didn't really need to starve people as long as we used to. A lot of times it was like, stop eating at midnight and your surgery might be at 3 o'clock the next day. And patients then, their body kind of goes into a starvation mode. And we found that if we gave patients, we called a carbohydrate loading, so some apple juice or things like that a few hours before surgery, that it helps reduce some of the stress of surgery and stress on the body. Of course, nutrition, smoking cessation also is very important. During surgery, we also have been more attentive to not flooding patients with too much fluid. We standardized how we're giving the analgesia or the pain medicine and anti-nausea, antiemetics. And then also we really focused on not relying on opioids or narcotics as a primary pain source. There's a lot of issues, of course, with opioids and narcotics. They're a good pain medicine, but they have so many other side effects. And so we really found we could substitute a variety of different pain management strategies that really markedly reduced patients' need for narcotics or opioids, either during surgery or after. And then after surgery, again, kind of scheduling different analgesia, really getting patients up moving very quickly after surgery rather than being bed bound. We also found we could feed patients pretty quickly after surgery, not kind of starving them for days and days on end, and then really being attentive to making sure the bowels are moving. Benefits of the enhanced recovery after surgery is helping patient recovery, patient satisfaction, having more kind of knowledge and say in their surgical care. And then of course in the hospital, not having patients have more infections or readmissions for complications. And this is just a very brief picture. I'm just looking at time here of a care map of what we developed to give patients before and after surgery, so that you kind of know what to expect. Patient education is very important in all of this, and I think we spend a lot more time kind of helping patients understand what to expect and what to expect after. What's next in terms of surgery? Just briefly, so I think we'll see continued expansion of different surgeries, kind of, again, more difficult surgeries with robotics. AI is definitely artificial intelligence is a huge area of development in surgical training and in all aspects of medicine. I think one of the clearest areas that we'll adopt more is in our trainees, is being able for them to do more simulated environments. In the surgical suite, I think we're still kind of grappling with that. I'm not sure folks are really ready to have automated surgery, but there may be some aspects, like for example, alerting, looking at the anatomy and the AI assistant saying kind of, this is what I think is going on, to maybe alert the surgeon to make sure to prevent any injuries, but that's still kind of TBD. So anyway, thank you for attention. Sorry, I know I started a little late, but happy to look at questions in the chat. Let me just stop my thing. Okay. Stop share.
One of the questions that was asked first talked about a panel, attendee asked Dr. Gray, can you speak to spread to the omentum?
Oh, that is a great question. Okay. Most endometrial cancer does not spread to the omentum. The omentum is this little fatty apron that hangs off the large colon or transverse colon. There are some endometrial cancers that have a little bit higher risk of spread to it, one called a serous cancer or clear cell cancer. Most folks who have endometrial cancer, it's what's called endometrioid, and it has very low risk of spread to the omentum. But if you have one of these special or less common diagnoses, clear cell cancer or serous cancer, many times your surgeon will recommend a biopsy of that omentum at the time of the surgery to make sure there's been no spread. Good question. Thank you for asking that.
There is also a question about the use of PET-CT preoperatively.
Yeah, that's a great question. You know, again, and this is where there's a little bit of individualization of patients I would speak to. In general, for most folks who are diagnosed with a potential early stage endometrial cancer, we usually just do an ultrasound as our preoperative diagnosis, because surgery is going to involve removing the lymph nodes as well too. Again, in those we call higher risk histologies, the clear cell or serous cancers or sarcomas, we do usually recommend a CT scan looking at the lungs, the abdomen, the pelvis before. PETs can be useful if you are trying to clarify if there's something abnormal on a CT. We don't usually use it as a preoperative tool, but it can be useful. For example, if something was seen on a CT, there was a spot in the lung or spot in the liver, and you're like, is this really a spread, or is this something we need to investigate more? And that time, usually your provider will order a PET scan. Good questions, really important questions.
There's another question just about essentially, does the impact of the executive orders to leave the World Health Organization and whether that will impact our access and contribution to international studies or standard development? I think the short answer to that is, you know, number one, that this is something that we're all being kept abreast of very often and very frequently by our organizations, the Fred Hutch Cancer Center and the University of Washington. And I think, thankfully, the short answer to that is no, because those collaborative studies have multiple channels besides the WHO. So I think the short answer is no, but I think the longer answer is it's something that we're being kept abreast of on a daily basis by our organizations to make sure that our ability to advance the care of gynecologic patients is not being changed, or any cancer patient, I should say.
Yeah, I mean, I think we are in, yeah, go ahead. I just was
Oh, sorry, you go ahead, Dr. Gray.
No, I was just going to reiterate. I mean, these are some challenging times we're having most recently, and we're trying to understand the effect it may have. I would say that we are, at University of Washington and Fred Hutch, we are 100% committed to our mission of focusing on, patient care, patient safety, and navigating these kind of unknown waters right now, but we're still very involved in all of these aspects and committed to your care.
One last question is, what is the risk of perforating the uterus? And if it is perforated, could that cause spread of the cancer outside of the uterus? I believe this is referring to the use of the uterine manipulator at the time of surgery.
Or the biopsy.
Or the biopsy.
Yeah. It's pretty low. I mean, there was like kind of a corollary. I know we're kind of at break, but so if you need to drop off, that's fine. Sometimes when folks have that hysteroscopy we talked about, where the camera goes inside the uterus to make the diagnosis, there was a concern, well, could that then like cause spread of cancer because you're pushing cells out? And actually that's been shown not to increase people's risk. So I think the same thing with the perforation. It's probably, I think there isn't really a risk. Cancers, when they want to spread, they've developed kind of an aggressiveness about them that isn't, that's unique, not just to kind of a surgical manipulation, if you will. I'm not sure that answered that 100% correctly.
There's also been some studies that have looked at, say, there've been some thought, well, if we do some perforation, could it result in cancer spill, say at the time of hysteroscopy? And there've been some follow-up studies that have suggested that even if that's found, that it doesn't impact long-term patient outcomes. So I think that's a great question. And thankfully there continues to be ongoing work about it, but at least to date, it doesn't seem to show that even if there was perforation or spread outside of the uterus, that it has any adverse outcomes. Then the last question is,
I think we're going to let's just pause. We can address. We'll make sure we bring up some of these. We'll answer. I do want to give people a break just for a minute because I think we are on our break is until 10:20. Is that correct, Ritu?
Correct.
Okay, so I just want to give everyone a 5-minute break. I'm going to turn my monitor off and I'll join back on at 10:20, and I'll ask Dr. Rodriguez to join and Dr. Urban, but we're just going to take just a little bio break for a minute. But really, thank you everyone for joining, and appreciate. We'll keep the questions coming. We'll make sure we answer them during. Okay, thank you. Give everyone a minute just to all right, welcome back. Oh, I got a lot of sunlight coming in, which I am not going to turn down. So my face looks very brilliant. I'm just going to enjoy it. So welcome back. Thanks again, everyone, for joining. Again, just to remind that we are presenting patient from a patient viewpoint information on uterine and endometrial cancers. And we're now going to switch gears a little bit, and I'm going to introduce Dr. Izzy Rodriguez, who is faculty here at University of Washington, Fred Hutch. She is a GYN oncologist, again, trained in specialty management of GYN cancers, both surgery and therapeutics. And she is going to be talking to us today about kind of this new world of molecular classifications of tumors, and I think also maybe talking a little bit about some staging as well too, and answering questions about that. Welcome, Dr. Rodriguez.
Thank you so much, Dr. Gray. All right, I'm going to share my screen. Okay. All right, is everyone seeing the appropriate
Yes.
slides? Great, okay. Okay, so good morning, everyone. Thank you so much for coming. I'm Isabel Rodriguez, one of the GYN oncologists, and I see patients at University of Washington and Fred Hutch Cancer Center. And then I also see patients in our cancer prevention clinic. Genetics and molecular medicine is near and dear to my heart. And so I'm going to be talking about sort of a newer element of how we talk about endometrial cancer, which is molecular subtyping. And why we're specifically talking about this is because it's now standard information that's being reported for endometrial cancer. So you're going to see it in your clinic notes. You're going to see it in your pathology reports. It's changed how we assign endometrial cancer staging, and it's starting to change how we approach treatment, allowing us to personalize treatment recommendations and really do what works best for each person. That being said, it's also one of the more complicated things that we discuss with our patients. And so this morning, I'm going to talk to you about the history of how we identified these subtypes, how we do the testing to assign the subtypes, and how this may change the treatments that we are recommending. So ultimately, how this will benefit you. Just to start with some background. So whenever we have a new endometrial cancer diagnosis, we talk about two different important components of that diagnosis. So the first is histology, which is the microscopic assessment of tissues. And so basically, when you have a biopsy performed or you have surgery done, and we send that tissue to pathology, this is what the pathologists are doing to be able to give us a diagnosis. They basically slice up the tissue into really thin segments and put it on a slide. And so you'll see a lot of these types of slides in this talk because this is how the pathologists are helping us make these diagnoses. And there are really two main things that they're looking for. So two main pieces of information that they're going to tell us. The first is type. And so we have alluded to this a bit already in previous talks, but there are different types of endometrial cancer. And so some of the types that you've heard about so far are endometrioid, clear cell, serous, and carcinosarcoma. Endometrioid is the most common. It's 80 to 90% of endometrial cancers. Serous is around 10%, and then the remaining are smaller numbers. And the second thing that they're going to tell us is grade. So grade is a description of how abnormal the cancer cells are compared to normal tissue. And so basically compared to what normal endometrial cells look under the microscope, how abnormal are they? And the grading system is grade 1, 2, and 3, with grade 1 being the closest to normal and grade 3 being the most abnormal. And really in endometrial cancer, we only use this for the endometrioid type. As you can imagine by the name, endometrioid looks the most similar to endometrium. And so if it's, lower grade changes, that's encompassing grade 1 and 2 versus high grade changes is grade 3. And then all of our other subtypes that are not endometrioid are considered high grade, basically by definition. And this is different from stage. So stage is a description of where the cancer is in your body. So every type of cancer has its own staging system, but generally speaking, stage 1 means that the cancer is located in the organ where it started. Stage 2 means that it's spread in the neighborhood. Stage 3 is spread farther away, involving lymph nodes or other organs. And then stage 4 is distant spread, so to another cavity, like from the abdomen to the chest, or invading through another organ, something like that. So why do we want to know all this information? The reason why we want to know is because it helps us better predict the behavior of the cancer, meaning how fast growing it is, how likely it is to come back after treatment, how it may respond to treatment, and also on average, how people will do over time. And so really up until this new classification system, what we were mainly using to make those decisions was the information that I talked about. So grade and stage. But as you will see, that's not the whole story, and we've gotten a bit more precise. So just to talk about how we used to think of endometrial cancer, we used to put people in two categories, type 1 and type 2. This was a system that was introduced in the 1980s and was really how we thought about endometrial cancer for about 30 years. So type 1 endometrial cancers are the most common, representing about 80% of cases. This was characterized by low grade, so grade 1 and 2 endometrioid histology, and it was a process that was driven by excess estrogen being exposed to the endometrium, basically promoting growth of the lining of the uterus. Generally speaking, these were considered to be less aggressive or better behaved, diagnosed at an earlier stage with a lower chance of metastasis spread and a lower chance of recurrence. Type 2 endometrial cancer is less common, representing around 20% of endometrial cancers. And so these cancers were high grade, so either grade 3 endometrioid or one of our other high-risk subtypes like serous clear cell carcinosarcoma. These tended to present in older patients and in a state of estrogen atrophy, so not necessarily due to estrogen effect on the uterus, but other mechanisms. And are seen in a higher frequency in non-white patients. Additionally, endometrial cancer, unfortunately, has the reputation of being a cancer type that it has increasing mortality rather than decreasing mortality in the last 10 years. And these type 2 cancers are really driving that. These are more associated with metastasis, higher recurrence rates, generally worse behaved. So why isn't the type 1 and type 2 classification good enough? This is, again, it was mainly using the information we were getting from the pathologists, the grade and the stage. The truth is that a lot of the time, this classification was good enough. It did help us predict how patients would do, and we could tell patients with type 1 cancers that generally they were going to do pretty well, and type 2 cancers we were more worried about. And so we often did more treatment for those patients and counseled them differently. The problem with this classification system is really mainly with this group, which I've outlined in the red box, the high-grade endometrioid cancers, which was a very, very diverse population. We had some high-grade endometrioid patients that did really well and other patients that did not. And so it was hard to know how best to treat them. So then in 2013, this landmark study came out where basically they used a bunch of different molecular tests and genetic tests on 373 endometrial cancer samples. And what the authors found was that instead of there being 2 distinct groups, there were actually 4 groups, which I put in the boxes along the top here. And so they may be familiar to you if you've seen them, again, reported in your pathology report or in clinic notes. But these 4 groups are called POLE, DMMR or MSI, copy number low, which we now call NSMP or no specific molecular profile, and then copy number high, which we now call P53 abnormal. This is a figure from the study that's called a Kaplan-Meier curve. So essentially it's a type of graph that shows the probability of a patient either remaining free of disease or surviving from a disease over a period of time. And so the 4 subtypes are represented in the 4 lines in different colors. And this graph specifically is showing the likelihood that patients in each of these groups remain disease-free over time. So these are the patients that were in that landmark study. And so essentially, we see 3 different groups in terms of how patients did. The POLE tumors did the best. And then there's this intermediate prognosis group that includes both the DMMR MSI and the copy number low patients. And then the copy number high patients were the most likely to have a recurrence. And what I want to point out in this gigantic figure with lots of very lovely, colorful boxes is this data that's shown in the bottom 2 lines. So basically, all of these patients had endometrioid histology in the first 3 groups, for the most part, not completely, but the vast majority. And what you can see here is that basically, despite the fact that a lot of the POLE tumors were actually high grade, they did the best. And then these copy number low patients were almost exclusively low grade, and they were an intermediate prognosis group. And then over here, we have the copy number high patients. And so as expected, these patients had a lot of different histologic subtypes, including serous for the vast majority. And this is our the group that did the worst. So let's go into each subtype and talk a bit about what they mean. So the first is called POLE or POLE ultramutated. It's the least common subtype. About 7 to 9% of endometrial cancers are POLE. These cancers have a mutation in a gene called DNA polymerase epsilon, and the job of this gene is to basically help proofread DNA during replication. As our cells divide, they naturally make mistakes. And so we have lots of different mechanisms by which our body tries to correct those mistakes or prevent those mistakes. And when we can't do that process, as you can imagine, we end up with a lot of mistakes, which essentially are mutations. This tends to present in younger patients with a lower BMI, and under the microscope, these tend to look aggressive. They look high grade, they can look very scary, but that being said, these patients tend to have the best prognosis. The second group is DMMR or MSI, which it has two names, and that can be very confusing as well. And we'll talk about what those two names mean. But basically, this is about a third of endometrial cancers, and it's also caused by a different problem with a process for fixing errors that are made as the cells divide. So again, these tumors also have a lot of mutations because of the problem with fixing those errors. And so DMMR stands for deficient mismatch repair, which is that fixing process that I talked about. And that is the cause that we're testing for. And then MSI is microsatellite instability, which is basically what what it looks like when you have this error. That's like something that we can observe in the DNA. That's the effect of having a problem with this type of DNA repair. These tumors can be secondary to Lynch syndrome, and actually doing this test for patients is a genetic screen. And so a very normal, natural question when someone's diagnosed with a cancer is, do I have to worry about this for my family members? And so essentially, we are assessing that for you. So this is a genetic screen, and I'll talk about it a little bit more at the end of this talk when I go into genetics. But not everybody with DMMR or MSI endometrial cancer has Lynch syndrome. In fact, the vast majority do not. The histology can be high grade or low grade. So these have a variety of appearances under the microscope. And the other thing that's very important about this group is that there's an FDA approval to use immunotherapy for patients who have this type of endometrial cancer with advanced disease or metastatic disease or recurrent disease. And so we have lots of studies showing that this is a very effective therapy, and specifically in this group. The third group is kind of a catch-all group, no specific molecular profile. And this makes up about half of endometrial cancers. And this is a big proportion of what we used to call the type 1 endometrial cancers. So it's associated with an excess of estrogen and that effect on the endometrium. It's mostly low-grade endometrioid, and it's one of the intermediate prognosis groups. And then the last group, which was previously called copy number high, but now the new terminology is to call it P53 abnormal. Reason being is because it's from a mutation in a tumor suppressor gene called TP53, which is a gene that helps prevent our cells from growing uncontrollably and becoming cancer. This is about 15% of endometrial cancers. It tends to present at an older age and in patients with a lower BMI. And a lot of these patients have serous endometrial cancer, but about 25% of grade 3 endometrioid cancers will be in this category. And this subtype is the most aggressive, has the highest risk of metastatic disease, highest chance of recurrence after primary treatment. So as Dr. Gray was mentioning, these are the patients who we actually do sample the omentum because of the risk of basically spread in the abdominal cavity. So here's a slightly different way of looking at it. The bright yellow boxes show our old system, type 1 versus type 2. And basically you can see that all of these groups do have crossovers into all the 4 categories. But I think what's most interesting about this is that, again, the grade 3 endometrioids are very well represented in all 4 molecular subtypes. And so basically this group can behave very differently depending on what is the genetic driver for why these cancers occurred. So just to summarize this first part, we're currently classifying endometrial cancer into 4 subtypes, which I've listed here. They help us do a better job at predicting how endometrial cancer will behave. And in particular, they give us a lot more information about the grade 3 endometrioid cancers, which can behave very differently. So because these are so helpful for us in counseling patients and deciding on therapies, multiple cancer organizations support molecular testing for all patients with endometrial cancer. And so how are we doing this test? There are 2 main ways. So one method that many labs have in place just within their own institution is immunohistochemistry, or IHC. And again, you're seeing these slides where we're seeing thin pieces of tissue that are put on a slide and they have stains applied to them. So these are tests that the pathologists are doing for us. We can ask the pathologists to do this test and they can report that information. And so there's tests where we can basically do MMR staining to see if you're in the dMMR group. P53 staining. Importantly, with this method, we still do need to do a non-staining or non-AHC test to look for POLE called hotspot sequencing. And then at Fred Hutch and University of Washington, we are very fortunate to have wonderful laboratory medicine department. And actually, we recently collaborated with them in the last couple of years to do all of our molecular classification using a technique called next generation sequencing, or NGS. And that allows us to look at many genes at the same time. So a few years ago, we were already using this method to do genetic screening for Lynch syndrome in all of our patients who had endometrial cancer. But basically, that's not all that we can get with this. And so we realized that we could report out these other subgroups because we were already using this method. And so we started doing that. And as of a few years ago, every single patient who's had endometrial cancer surgery at our institution gets this information reported in their pathology report. I think one really important thing to know about it is that this aspect of your testing takes a little longer. So your pathology report will come back in about 7 to 10 days, and we'll have that information ready to go. And that'll tell us the type of endometrial cancer and the grade and the stage. But this molecular information takes about 3 to 4 weeks to come back. And so it's something that we'll address again in a later visit, especially as we start talking about whether or not you might need more treatment, because this impacts how we decide what we do. And then once we have the molecular information from either IHC or NGS, we can assign you a category. And so we use the following approach. The first question we ask is there a POLE mutation? And if there is, then you fall into the POLE group. The second question we ask is there MMR deficiency or MSI? If yes, then you fall into this group. And then if neither of those first 2 apply, we ask, is there a P53 mutation or not? And that gives us the final 2 groups. Another big exciting update, there's a new staging system that was introduced for endometrial cancer in 2023. So not quite as hot off the presses anymore as it used to be, but still very recent. And basically it incorporates what we know about the different molecular subtypes, and it gives different stages based on both the histology information, so that a type and grade. But then, very interestingly, our new staging system also incorporates the molecular data, and that can change your stage. So patients with POLE mutations are assigned a lower stage if that POLE mutation is in a patient who has cancer that's just in the uterus, hasn't gone anywhere else. And then similarly, even patients who have very early stage P53 abnormal endometrial cancer, they're actually assigned a higher stage as a result. And so in summary, there are different methods that we can use to test for molecular subtype, which is now a part of the newest endometrial cancer staging. And so if you look in your pathology report, or your clinic notes, you may see that the stage now looks like this. So you'll get a stage, which will be a number and a letter, then a lowercase m, and then this subscript, which will be your molecular subtype. Okay, so we have made this very complicated classification system, and it helps us counsel patients better as to how we think their cancer will behave. But what do we do with that information? How does it help us make decisions? How does it help us pick the best management for each person? And that's basically where we are at right now. This is the most cutting edge area of endometrial cancer in terms of articles being published, clinical trials that we're doing. Since we've identified the 4 subtypes, there have been multiple papers where folks basically went back and analyzed some of our big endometrial cancer treatment trials to see if treatments are more effective in some subtypes than others. And this is just one example, but basically this was a study that looked at 2 of our early stage endometrial cancer trials where we were giving patients different types of radiation therapy and broke it down by molecular subtype to see what treatment was most indicated for each subtype. The caveat here, because we get very excited when this information comes out, is that these studies all took place before we had molecular subtyping, and so they weren't necessarily designed to answer that question. And so they give us clues as to how different subtypes might respond differently to different treatments, but it doesn't necessarily confirm it. And so essentially what we're doing now is several ongoing trials to answer this very question. Basically, do folks do better when we choose treatments based on subtype versus just basing it on stage and grade? And here are 2 of the trials. The first one is called PORTEC-4A, and it's looking specifically at patients with early stage or stage 1 endometrial cancer, and then putting them into essentially favorable, intermediate, and unfavorable prognosis categories. And then the control arm or standard arm means that all of these patients are getting the same treatment regardless. And our experimental arm here means that we're giving patients different treatment based on their subtype. And then the second study is called the Rainbow Study, which is really a group of 4 trials, 1 for each subtype. And so it includes stages 1, 2, and 3 endometrial cancer and has different treatment arms that are being compared within each subtype, again, so that we can more appropriately pick a treatment for each person. So all of this is important because there are prognostic implications, so we can predict how patients will do. There are predictive implications, meaning we can have a sense of how different treatments are going to be most effective for each subtype. And then as an added bonus that I referenced earlier, this is also a genetic screening test for Lynch syndrome. So we're going to take a brief sidebar and talk about genetics. Lynch syndrome is a hereditary cancer syndrome, so you can pass it down through the family. It's associated with risks of multiple different cancers, including endometrial, ovarian, colon, urinary tract, stomach, small intestine, multiple other cancers. So while only 2 to 5% of endometrial cancers are because of Lynch syndrome, it's really important that we identify who has it because it could mean that you're at risk for other cancers, and so you might need extra screening. And also, this is really important information for family members who might be at risk. And endometrial cancer is the first presenting cancer in about half of patients with Lynch syndrome. So even though the majority of endometrial cancer is not caused by Lynch, because of all of the reasons that I said, our governing body has basically recommended Lynch screening for anybody with a new cancer diagnosis, and it's something that we've been doing for years at this point. Briefly, Lynch syndrome is caused by mutations in several different genes. And so your specific cancer risk, if you have Lynch syndrome, depends on what gene you have. So as you can see, there's a wide range with some of the genes resulting in like significantly higher ovarian cancer risks than others or colon cancer risks than others. And so basically, if you're found to have this genetic mutation, we have you meet with the genetic counselors as well as multiple members of GYN oncology, GI oncology, basically to help come up with a good prevention plan for you. Lynch syndrome screening methods, again, they're the same as what we were referencing before because we were already doing them, but basically you can test for this using IHC or that staining test that we talked about that the pathologists are doing. You can also do it like we do here at University of Washington, which is to use the next generation sequencing to look for MSI. And it's really important takeaway from this is that both of these tests are screening tests, so they're not diagnostic tests, meaning that the goal is to identify who is at high risk for Lynch syndrome, but then we have to funnel those folks to actually get a diagnostic test. So this is the algorithm that we use, and from this very busy algorithm, I want you to take away 2 main points. Number 1 is that the majority of patients with dMMR or MSI endometrial cancer do not have Lynch syndrome. So if you fall into this subtype, we automatically do a second test that's highlighted in this box to help us determine who needs to go see genetic counseling and who's at risk for being positive for Lynch syndrome. And then the second big takeaway is that if you have a strong family history, we recommend that you see genetic counseling regardless. So it doesn't matter what your molecular subtype is, we still want you to see them because we don't want to miss any genetic causes of endometrial cancer that might be important for you or your family. And then very briefly here are a few other genetic risks for endometrial cancer. There's another cancer syndrome that's called Cowden syndrome. It is not common. It's estimated to affect about 1 in 200,000 people. And just for context, Lynch syndrome is around 1 in 300 people. There's an increased risk of multiple different cancer types. Family history is an interesting one. So basically, when you talk about risk factors for any cancer, we always talk about if your family member had it, you're probably at higher risk of having it too. Generally speaking, we don't feel like there is a large increased risk for patients who have a family member with endometrial cancer, unless there's a genetic cause that we've identified. So estimated risk is around 3% compared to 2%. But again, these studies are a little fuzzy because some of them didn't necessarily take out the people who have a known genetic cause, like the Lynch syndrome carriers. And then there's a possible increased risk of serous endometrial cancer in those with BRCA mutations. And the data is a little inconsistent here, but essentially the risk is overall still quite low. And it's really felt to be more consistently a signal in patients with BRCA1 mutation specifically rather than BRCA2. Okay, so in conclusion, molecular classification improves our understanding of prognosis and helps guide our treatment options in endometrial cancer. Some big takeaways for our polymutated patients, we're probably going to be trying to do less. And so we're doing studies to make sure that that's okay. And for P53 abnormal patients, we want to do more because we want to, again, optimize how patients are going to do. So escalating therapy. And then also they can give us other helpful information like telling us who may benefit from immune checkpoint inhibitors, and then also detection of Lynch syndrome. All right. Thanks everyone for your attention.
Thank you, Dr. Rodriguez. That was excellent. And there's some questions that have come up in the chat. I'm going to direct a few to Dr. Rodriguez specific to her talk. There was one that was asked about hormones and safety, and Dr. Urban's going to address that in her talk at the end. So just to be clear. And then there was a question about CT scans, and we'll address that a little bit later because I want to get up to the other questions. One was, specifically like what I think you'd mentioned, the older age of onset. And so a patient asked, like, what do we mean by that? Like, what age is considered older age?
That's a good question, and it's all a little bit relative, but generally speaking, the average age of diagnosis is kind of in the postmenopausal, early postmenopausal period. And so for patients with these type 1 cancers, we're seeing them more in like the late perimenopause period or even younger than that. And then for patients who
which is like around like 55 to 60.
Oh yeah, 50, yes, 50. Sorry, the average age of menopause is 51.
Yeah.
Yes.
So kind of, so average age is like for patients diagnosis is usually around 60, 62, right? And then so older age, we kind of think about 70 and up start to be kind of, but those are, as you know, definitely very relative. And then I think the other question, which is kind of an interesting one, someone asked if, for a serous cancer diagnosis, is there any need to bother with molecular classification if you're already going to like do more therapy, I think is kind of what
It's a really good question. I think for serous endometrial cancers, even if we happen to find, a poly mutation, none of us feel comfortable de-escalating therapy right now. Dr. Banda is going to talk a little bit more about like targeted therapies and precision medicine. And so there's still value in getting these molecular subtypes because, again, we may find information that can provide other treatment options for serous endometrial cancer. For example, they can be dMMR MSI, and so we may be more likely to add an immune checkpoint inhibitor for those patients. And so it still is a value, but I think another important point is that like this is something that is newly adopted in the last few years, and we're going to know more in 10 years than we know now. So I still think it's a value because it's giving us information that can help you now and that also may help others later.
And there was another question before we get to Dr. Banda's talk, because these are good ones to address as you are participate in the high risk group at the Hutch. A patient asked that her and her sister were both diagnosed with endometrial cancer, but were negative for Lynch. And is there any suggested additional screening for their daughters?
That's a really good question. And so, like I said, in terms of having a first degree relative with no genetic susceptibility, we don't necessarily know that that confers a significantly higher risk, but it makes us a little bit more suspicious. There are also lots of other things that can contribute to risk of endometrial cancer, like environmental factors, shared health conditions. We didn't talk about it really in this talk, but I don't know if Urban's going to get to it later, but certain like health conditions like diabetes can put you at higher risk. And so there may be other modifiable family lifestyle and health risk factors. But there isn't necessarily a screening protocol that we'd recommend. Like Dr. Gross was talking about, we want everyone to be aware of the potential symptoms of these cancers so that if you do notice something that's abnormal, you feel empowered to bring it up to your doctor, and so that doctors feel empowered to take it seriously and do the workup that you need to have.
As a follow-up to that, would you, for in the high risk clinic, are these questions that could be answered in like would this, would it be recommended for them to be seen in a high risk clinic to kind of talk through this, or?
We're willing to see anybody who has a strong family history and wants to learn more about what they can do to optimize their health. So that's absolutely something that we can see in the high risk clinic, and especially if it gives your family some more information and some peace of mind.
Okay, I'll let Dr. Urban.
Sure, I think just a few additional questions. So one question came up is, would it be helpful for patients on the call to give your group access to all of our records for the study? And so Dr. Rodriguez's study has concluded, but many thanks for being willing. Thankfully, our patients who have surgery for endometrial cancer, we maintain the tissue in some ways for this exact reason, so that we can do more studies as studies come up. And so I think the short answer is we appreciate the willingness, and we have the ability to be able to do research in the future in a way that is respectful to our patients. Dr. Rodriguez.
I just want to put in a plug that we do tumor banking at University of Washington, which of course is completely voluntary, but I want to put in a plug for it because this is exactly the kind of information that leads to these studies that we're able to do to be able to understand cancer better. And so when you're going in for your consent visit for surgery, we may mention the idea of tumor banking to you. And if anyone is comfortable participating, we absolutely love it. We can talk to you about the risks and benefits, but it is such a help to us.
And I think the difference between using tissue as opposed to tumor banking is that when we're allowed to collect the tissue at the time of surgery, we can essentially preserve it differently. That allows us to do different tests on it compared to, say, going back and looking at tissue years later.
I think we should probably move on. We're running a little behind. I know there's more questions, and we'll either get to them back in the chat or we'll make sure we get them at the end. Dr. Banda is going to be able to address some of the questions that have talked about specifically about matching treatment. So it's a good segue. Thank you for those questions. I want to introduce Dr. Banda. We're very grateful for Dr. Banda and his expertise. He is a medical oncologist, but is specialized in GYN oncology and therapeutics, and is just a brilliant mind, and really looking forward to his talk, talking about precision medicine. Many of us have heard these terms, and then the treatments in endometrial cancer. Welcome, Kalyan. Dr. Banda.
Thank you, Heidi and Renata, for inviting me. It's such great talks today. Dr. Rodriguez did such a great job. I'll keep mine very short. Yes, I'm a medical oncologist. I don't do surgery. I try to do surgery, but Dr. Gray and Dr. Urban don't let me. Especially, I really want to meet that robot. Sometimes I have fantasies of like being friends with the robot, talking to the robot. But then I realized today that it's not really a robot. It's just an instrument that does surgery. So that's how much I know about surgery. But I do know a little bit about precision medicine, not too much, but I can talk about it. So what do we generally mean when we say precision medicine? The other term that people use sometimes is personalized medicine. And the basic definition is that you're trying to tailor whatever treatment you have to the individual characteristics of each patient. But to be fair, we've always done this since the dawn of time. Any treatment that you have for any disease, you want to individualize this to the patient, how they feel, their values, their beliefs, their other medical conditions. So we've always done personalized medicine. Specifically, what we're talking about here is how do you pick the right treatment for the right patient. Meaning, how are you going to maximize the benefit and minimize the side effects? That really is the essence of precision medicine or personalized medicine and oncology today. And so let's talk a little bit about how it came about. So in 2001, 2002, I remember this because I was in school. There was this revolution of precision medicine, and it started with this disease called chronic myeloid leukemia, or CML, which used to be a terrible disease. People always had it and they end up dying. And then there was a drug called Gleevec or imatinib that was discovered. And it became a huge story, and Time magazine covered it and said, these are the new bullets against cancer. And it was such a great idea because CML is a cancer that has one single genetic mistake or mutation or abnormality. And there's one drug that can target exactly that mutation or abnormality and really turn it from a deadly disease to something that's chronic. People can now live a full life with CML just taking a pill a day. So a pill a day keeps the oncologist away. And that was just such a revolution that we said, this is the future of cancer. We now need to find that magic bullet for every cancer, and we can make every cancer a chronic disease. Not so simple, because no other cancer, in fact, other than CML, has that one single thing that drives it. Cancers have several or hundreds of mutations that really drive it. So now, if you look at lung cancer, it's sort of the modern poster child where lung cancer is now actually a dozen different kinds of cancer, each of which is driven by one particular or a major mutation, major mistake. And so you target each of these, and you've effectively created a dozen different cancers that do pretty well. So the goal is you're going to target these unique vulnerabilities of each individual's cancer. But what are these vulnerabilities? The thing about cancer is there's something very unique about it. It is part of us. It comes from our own body, but there is very unique behavior to a cancer cell compared to a normal cell. And many of us know this instinctively. One, the cancer cell just grows endlessly. It keeps escaping death. It goes from one place to another place, and it's not, any normal cell is not supposed to do that. It grows its own blood vessels. It feeds itself. It escapes the guardians that are supposed to attack it. It escapes the immune system that's supposed to find it, and just finds a way to feed itself. So there are some unique behaviors to cancer that are not seen in normal cells. That's what makes it a cancer. But that gives you this unique opportunity to target these things. If you target these things that exist only in the cancer, you can kill cancer by protecting normal cells. But you also need to meet some additional conditions. One, it's actually a scientific term called oncogene addiction. The cancer cell has to be really addicted to or dependent on some condition, some abnormality, some mutation that it keeps feeding off of over and over again, sort of the Achilles heel. Because if there isn't that one thing that keeps driving it, how are you going to target it? And the second condition you need to be, which is more difficult, is that you need a drug. But the drug has to act in such a way that there's the Achilles heel, you add the drug, and the cancer cell dies. If you have the Achilles heel, you have the drug, but the normal cell does not die. That is a difficult, two conditions to meet, which is why it is difficult to design drugs, even targeted treatments for cancers. But today, in what precision medicine is generally in practice, is that you're trying to find that mutation, that abnormality, something that's unique for which a drug already exists or sort of a treatment already exists. And I can give you some common examples that Dr. Rodriguez already talked about. For example, we've had for HER2 new positive cancers, many different cancers, you've had Herceptin. Those kind of cancers are just continuously fed by this HER2, and then you find a drug that targets only the cancer and not the normal cell because only the cancer has this HER2. Same thing for BRCA positive cancers. We've used now PARP inhibitors really well for a while for these cancers because they only kill the cancer cell, they don't kill the normal cell. So that really is how it functions nowadays, is in modern practice. So how does it really work in uterine cancer today? Dr. Rodriguez already talked about this. You have a new diagnosis of uterine cancer. You're using the genomics, some biomarkers, all of those things that exist to classify that cancer into separate cancers and understand the risk of it coming back. And based on how you classify it and how the risks are, you're picking treatments. And let's give a few examples. Like Dr. Rodriguez mentioned, there's a poly-mutated cancer, there's DMMR cancer, there's P53 wild-type cancers, there's P53 mutated cancers. So the deficient MMR cancers respond exceptionally well to immunotherapy. So if you have a cancer and you say it's deficient MMR, we are absolutely going to use immunotherapy for those cancers, because even more than chemo, immunotherapy does a remarkable job. Poly-mutated cancers are also the same. Immunotherapy works probably even better than poly-mutated cancers. But the point being is that they do so well that often they may not need some of the treatments that other cancers need. So you step down on treatments. So you are personalizing the treatment based on an individual characteristic of that cancer. You pick the treatments or you step down on treatment based on that. So really, that's how we are using it today. And someone brought up a question of, well, if you have serous cancer, is there a point of doing these tests? I would say yes, because in a few years, there may not be serous uterine cancer. There may be only molecularly defined cancers. Maybe serous cancer is like 2 or 3 different kinds of uterine cancer. And so in a few years, we may not be using these histology. We may not be using the words endometrioid or serous or other clear cell. We might be just saying this mutation-driven uterine cancer, that mutation-driven uterine cancer. And so if uterine cancer today is 4 different kinds, there might be 8 different kinds in the near future. The other common way we use precision medicine today in the clinic is when there's incurable uterine cancer, you've already received what's called the standard treatment, usually chemo and some immunotherapy and something else. And you've said, well, how else can we target this cancer? And in that case, again, you use some genomics, some biomarkers, and you're going to try and find some new treatment that we haven't used so far. And in practice, usually those treatments that we're trying to pick are treatments that have been proven in some other cancer, have been FDA approved for some other cancer, but right now we don't have an FDA approved uterine cancer. So you're trying to understand things from other cancers and try and use it for uterine cancer because you want your patients to do better. You want them to live longer, you want them to live good lives, and you try and deliver treatment. So in today's world, this is typically how precision medicine works in practice. So, but why? Why should you even care about precision oncology? And the reason is simple. It works. And it makes people live longer. One of the studies that people did was they took patients just with generally any sort of incurable cancer that have been through standard treatments and gave them treatments based on whatever like genomic or individual characteristics the cancer had. And they found that patients not only lived longer, very importantly, it didn't increase healthcare costs because this is a common complaint that you hear is that we're going to increase the healthcare costs with all of these treatments. Then came a giant study about a couple of years ago from actually UCSD, where they said, well, we'll take it a step further. We'll have a formal process by which we will complete for every patient that's sort of incurable and has been to all the standard treatments, we will completely study their genomics or whatever biomarkers they have. And then people will sit together like a tumor board, what's called a molecular tumor board, and we will pick treatments. Not only we will pick one treatment, we'll try and give them combination treatments. And people had thought it might work, but these people proved that when you did that consistently, patients lived longer and they did better in life. So this is a strategy that actually works and it has significant benefit. And that's why we should care about precision medicine or oncology today. As I told you, this is a very short talk. I would like to hear a lot of your thoughts on this. But precision oncology today has major pitfalls. And let's talk about a few of them. One, unknown targets. Meaning, we think we know a lot about cancer today. We continuously study cancer every day. Dr. Rodriguez has done so much research in uterine cancer, and she'll continue to do it for her lifetime. But even then, we may only know a portion of knowledge of cancer. That's just how complex human biology is. So we just don't know enough about the genomics of maybe an individual cancer to know how to even target. So meaning our knowledge may not be good enough today to find precision treatment. Second pitfall is too many targets, too few drugs. And what do I mean by this is that we may know a lot about cancers. We have studied, especially in the past 20 years, we've made remarkable advances in the genomics of cancers. So you know that there are these 100 or maybe 1,000 mutations that are just the most important things that drive cancers. But unfortunately, we only have a handful of drugs that target them. That's just that's just a testament to how difficult it is to get a drug for a cancer. And I can give you a really simple example of how the drug development process is. You want a drug for a new cancer? You have a lab with like 1,000 different molecules. You take those 1,000 different molecules and you put them on a petri dish with different cancers, and then you find 100 that might kill the cancer. And you take those 100 and you give them to mice, and you find that 80 of them will kill the mice. So you can't give it to people. And you take 20 of them and you give it to people and you say, is it safe for people? Maybe 10 of them might be safe. The next step, you give it to a few more people and say, does it work in people? Maybe 3 of them might work. And then you say, well, we'll take these 3 and then we'll compare them to like chemo or whatever the standard is. And maybe 1 at best might come through. And that's how that 1 drug out of 1,000 will get FDA approved. And that process might take decades, millions of dollars, and maybe thousands of patients who need to be on the trial for us to get that result. So it is inherently an extremely inefficient, expensive, and frustrating process. The other pitfall is too many drugs, too few targets. So the genomics or the genes are like having a recipe book. Without a recipe, you can't make something. But you can give me and you can give my wife the same recipe, and I can guarantee you that the products will look very different, even though we have the exact same recipe. Because there's something so much more important than the recipe in delivering the final product. And so is biology. We only know today about some part of the recipe, which is the genes. But there must be so much more than the genes that like really drive these cancers. And so if it is driven beyond the genes, we don't know what they are. So how do you find drugs for things that you don't know and you can't see? And so these are major pitfalls today of precision oncology. And there are strategies now we're thinking about to going beyond these just genomics. And these exist even in our own institution. And I'll give you a few examples if you don't mind. Going what's called functional precision medicine, where you're saying, listen, we may not know much about the genomics of each of these cancers, but we'll find a drug that sort of works at least in the lab. And if it works in the lab, let's actually try and give it to a patient and see, if it works. So in our institution, Dr. Elizabeth Swisher has already an ongoing trial like this for ovarian cancer. It's called Prosperity. And in the trial, what you do is you have a biopsy or surgery or whatever is happening, and you collect part of the tissue of the cancer. You grow these cancers in the lab over a few weeks. You test 50 to 100 drugs on them. And if something works, and if something is already maybe FDA approved in some other cancer, you can try and get these drugs for the patients. So this is a strategy that is being tested. We don't know how effective it is. It has to be proven. Just like we proved that to target the gene, it works, you have to prove that these strategies work. And that's exactly what Dr. Swisher is doing. So one advantage we think of this strategy is it sort of goes beyond genomics, meaning, as I told you, we don't know so much about cancer. So it just eliminates all of that and just says, if a drug works, maybe we can just give it to a patient. So until we catch up with the knowledge of what completely drives cancer, maybe this is a strategy that works. My hope is someday to test many of these strategies. There's many of these strategies today that exist even in the Fred Hutch. For example, one is done by Dr. Tarun Gujral, who has a trial ongoing at the National Cancer Institute at NIH for rare brain cancers. He has this technology that's a little similar that he calls Smart Match, where he takes tissue, he sort of puts it in the lab, he tests the small amount of cancer with only a couple of very clear drugs. And once he gets a response, he has an artificial intelligence program that then takes the response for these maybe 20 drugs and then extrapolates it to thousands of drugs that exist, and then picks the best drugs that work with the least sort of side effects. And this is done by this incredible computational like AI biology that exists. And in this way, he's able to do this clinical trial at the National Cancer Institute with these rare brain cancer. So this can be done at the National Cancer Institute. And this is someone that exists at Fred Hutch. We would like to do something like this for our own patients with these rare, especially rare cancers, including uterine cancers that don't have treatments that have already been given all the standard treatments that we know today. So it is my hope that later in the year, we will be able to open such trials, precision medicine trials for women with metastatic or incurable or rare gynecological cancers, including uterine, where we do the same concept that Dr. Lister is using in ovarian, but with a different technology. Because as I said, a lot of things in cancer are bound to fail. So the more strategies that you test simultaneously, the more chance of success we have. So one day it is my hope that later in the year we will be able to deploy the Smart Match trial in uterine cancers that have gone through their standard treatments. But I didn't talk to you about the biggest pitfall of precision oncology today. And this is the most shameful pitfall that we have, which is that you may have sequencing done, you may be able to find a drug, and you may have these brilliant minds who come together to say, this drug is going to work for the patient. You may even order the drug. You will never be able to get the drug for the patient because you won't find insurance or a drug company willing to give that drug to the patient. And this is really shameful because there's no point in investing billions of dollars and doing these incredible scientific advances if you can't actually deliver it. It's like, one of my friends said, it's like the moonshot. You create this incredible technology to go to the moon, but you forget to create the technology to come back. No astronaut is going to sign up for a one-way ride to the moon. So this is something that all patients and caregivers know acutely well. My only point being, all of us need to. I don't have any clear solutions to this problem, but what I do know is all of us need to continuously talk about it with insurance companies, with drug companies, with regulators, and with politicians. Without that, none of this is going to change. And without that, none of these precision medicine strategies are going to work. So to conclude, actually, I want to say that the future is very bright. There is a rapid change in the landscape in the next 10 to 20 years. Uterine cancer is going to be a dozen different kinds of cancer in the future someday. We will have enormous number of targeted treatments. Our technology is changing the rate at which we're getting new drugs. Simple things like AI. As I said, one day, in the way we used to do it, or we had to do it, is you test 1,000 drugs and see which one worked. Today, you can say, this is the problem. A protein, instead of being straight, is kinked. So AI, can you design a plug that fits in perfectly into the space and fills the gap? And AI today can do that, like really well target these things and manufacture these drugs. So our process of like drug development is going to be incredibly short compared to what has been in the past. What is a way for patients today to get access to the most state-of-the-art precision medicine therapies are clinical trials. Almost most clinical trials done today are in one way or another targeting some precision medicine therapy, something unique to the patient's cancer. They may include chemo, but that's not what's being tested. What's being tested is some precision medicine strategies. So it is the NCCN and the NCI recommend that clinical trials are one of the best ways for patients to get access to these drugs today. So please think about clinical trials. And one day soon, I hope that precision medicine will move beyond just genomics. We'll understand so much more about cancers and we'll be able to target all of that. And all of us, patients, caregivers, physicians, we all have to continue to advocate that our patients get access to these targeted therapies because that is crucial. That's really all I wanted to say today, but I would be happy to take any questions, thoughts, concerns, and thank you all for having me again today.
Thank you, Dr. Banda. That was really an excellent overview. And I think you gave a really nice messaging to help folks kind of understand. And I would just echo that, you know, as for all of us as providers, we know that this challenge of like we know the data is there, we know the drugs are there, and then just being able to deliver the right drug, the right time to the right patient is increasingly being challenged. And you know, we're very committed here at Hutch and UW to continuing this, but we also really do need patient advocates at that level, because I can tell you the politicians in government, they don't want to listen to doctors, they will listen to patients. You know, that it is the most important weapon we have is for advocacy is our patients, because they will make change based on what you say and what you care about. So please reach out to, you know, politicians, to anything about, you know, because I think we're all in this together, but we really do, we need to continue to be able to push the medicine forward for you. And we're very committed to it. So let me see it. Were there other questions? So I'm just looking at the chat for a moment.
I answered a few as we were going on, but I do think that one question that we didn't get to that maybe both Drs. Banda and Rodriguez can address is, how do genetic mutations influence the effectiveness of immune checkpoint inhibitors?
Mm-hmm.
Dr. Rodriguez, do you want to take that?
Yeah, so I would say that immune checkpoint inhibitor therapy is something that's really revolutionized cancer therapy in the last 10 years. If you watch any TV, you're going to see a commercial for an immune checkpoint inhibitor. It is useful because we are basically taking advantage of a mechanism within the cancer itself, not necessarily the origin of the cancer. So it's not just for endometrial cancer, it's for cancers who have alterations in a very specific pathway. So the way that immunotherapy works is that normally your immune system should be able to identify cancer cells as abnormal and kill them. But cancer's smart and finds ways to basically evade the immune system or basically turn immune cells away, say, don't look over here. And so specifically with endometrial cancer, we have basically some of those molecular targets that we know are effective for immunotherapy. So the DMMR MSI group, that's already a blanket approval for patients who have that finding, regardless of the cancer type, so not just for uterine cancer. But we also had 2 studies that were published very recently that showed benefit even for patients who don't have that marker. And so even if you aren't in that subtype, if you have an advanced endometrial cancer or recurrent endometrial cancer, it's very likely that immune checkpoint inhibitor therapy will be recommended for you, because we've shown that there is benefit even if you don't have this change. But the highest improvement in outcomes was in patients who did have this change or were in that DMMR MSI group. I don't know if you have anything to add, Dr. Banda.
That was very thorough. Yeah, nothing really to add other than yes. The answer is yes. There are absolutely genetic mutations that change how you respond, and there's a whole spectrum. And
just as an example, and I think, I can't remember if you brought it up, Dr. Rodriguez or Dr. Banda, but we actually think that the immunotherapy or the immune checkpoint inhibitors, we kind of use the term immunotherapy in that context, really might replace some of the chemotherapy options in some select patients, which would really benefit in terms of side effects and long-term effects. And so I think it's a really exciting landscape right now in terms of improving patient outcomes and reducing toxicities and side effects. And that's a good segue into a question that came up to Dr. Banda, because I know you see this a lot too, is what happens if you find a drug that works, but you start having a lot of reactions to it? Kind of what's your approach or to managing that?
Yeah, unfortunately, that is a very common scenario. And that's a huge part of the art of medicine, is how do you give these complex drugs while making sure that people are enjoying a quality of life and they can do the things that you want to do. And the answer is, again, it's not one size fits all. This is where I said that we always personalize treatment based on the patient's biology, their medical history, their beliefs, their thoughts, their desire. And so sometimes you have to cut the dose. Sometimes you have to take a break. Sometimes you have to switch it entirely. Sometimes you have to add medications to take care of the side effects. And sometimes you cannot just proceed with the medication. And so all of those above exist. And that's why it's so important to have that continuous relationship with your oncologist, because they're the ones who sort of learned about you for years, are able to, the two of you come together to a plan that helps you best. So I don't have a simple answer other than it's a lot of, it is truly personalized treatments and discussion with your oncologist.
Another question that came up is if your histologic type comes back as endometrioid NOS, what are the implications of NOS? I think that's a little bit tricky in that it depends where that type was coming from, whether it was coming from the uterus itself or from a biopsy, because we're always limited in some ways by the amount of cancer tissue. So I think it's a little tough to know, but I guess I would maybe ask your providers whether it's possible to provide any more information, like grade, as Dr. Rodriguez alluded to, and whether it's possible to do additional testing, whether through pathology or through the method of next generation sequencing, to get more information to better characterize the cancer.
I'm also wondering if that question's referring to like that no specific molecular profile group, which
got it. Great question.
I don't know. I'm not sure, but just
bring
just
it
to
back
speak
to your
on
provider, I would say, yeah.
yeah, just to speak on that a little bit, that is the majority of the endometrial cancer. It's about half. So a lot of people are falling into this group. And I think that's a group that honestly we need to learn more about. Like I said, it was sort of a catch-all group. It's the kind of the everyone else from this landmark study. But now that we are doing all this molecular subtyping and it's not just these 4 groups, we're also testing for other things too. I think we're going to learn more about this group and how we might be able to stratify it a little bit better. But it is sort of considered an intermediate prognosis group. And so when we're thinking about therapies, we are using that information to help us figure out what to do. And so it doesn't mean that we don't have information on what to do for you. I think it also means that probably in 10 years, we're going to have a lot more knowledge about what this group actually looks like, personally.
And then a couple more questions have come up, and I think one Dr. Urban is going to address, which is looking for signs of recurrence, right? I think, you're going to address that in the next talk? And then I think just the last one other question that got brought up again about immunotherapy, and I think Dr. Rodriguez and Dr. Banda spoke a little bit about, is that can immunotherapy be used not in recurrent setting, but as part of standard treatment? I don't know if either of you want to take that question just briefly.
It certainly is. And we're using it for a variety of indications in that primary setting. So not just for recurrent patients. So it's certainly something that we are considering for every patient who has advanced disease. So disease that's spread beyond the uterus, because that's those are the patients who are in those 2 big studies that were published in the last few years. And so that's something that we talk about when we talk about our patients in tumor board for every patient who has disease that's spread outside the uterus to other places. But there's also a lot of studies going on right now for even lower stage disease. So some of those patients might receive radiation or a shorter course of chemotherapy. And so there are a lot of studies going on right now to see like, hey, could we do immunotherapy instead? Could we do immunotherapy with radiation to make it more effective? So there are a lot of potential indications for immunotherapy, even if it's not recurrent, even if it's your first treatment.
And many times immunotherapy is given kind of as a maintenance. You might hear that term where maybe your CAT scan doesn't show any cancer there, but as a preventative measure so it doesn't come back. And that sometimes is 1 year to 2 years. So that can be a common, just in generic. I think we should move on to our last speaker, if that's okay. And again, please keep putting questions in the chat. We will keep rolling through and making sure we get answers back. That was an excellent talk by Dr. Banda. So we're going to move now kind of into the next section, which is really health promotion and survivorship. Dr. Renata Urban, my co-host this morning, is going to give us a nice overview, and we'll make sure we have time for questions at the end too that we didn't answer. Thank you.
All right, I'm going to make sure that my technology works. All right, Dr. Gray, can you see my screen? Okay, great. Well, thank you again, colleagues, for your excellent presentations. I'll be wrapping this up talking a little bit about health promotion and survivorship. And I've seen some questions in the chat talking about patterns of recurrence, symptoms of recurrence, modalities of surveillance. And I have information in this that will address this, and I'll also try to address as I'm going, but please, as Dr. Gray mentioned, please continue to put questions in the chat. So for those of you who don't know, September is Gynecologic Cancer Awareness Month, which represents all of the gynecologic cancers. But actually, June is now Uterine Cancer Awareness Month. So I put that up there just as a shout out. So I think it's important to note that there's places for everyone, but certainly September is for Gynecologic Cancer Awareness. And then we have the addition of June as for Uterine Cancer Awareness Month. So I'm going to start just by defining what a survivor is, because I think that this is actually a really important point. So the National Cancer Institute, if you go to their website and you define, well, what actually is a cancer survivor? So this is someone who is alive and continues to function during and after overcoming a life-threatening disease. But in cancer, really someone is considered to be a survivor from the time of diagnosis until the end of life. So whether you are living after treatment for cancer or living in the midst of treatment with cancer, either way, many of you on this call are survivors, and we're grateful for your attendance. So I wanted to start just by talking about, well, how many patients out there are actually living with endometrial cancer. So this is a graph here looking at the number of US cancer survivors. This was of the beginning of the year in 2022. And as you can see, I think first and foremost, there's nearly 10 million female cancer survivors in the United States, but there's nearly 900,000 endometrial cancer survivors. Endometrial cancer is the 7th most common female cancer worldwide and the 2nd largest group of female cancer survivors. And one of the challenges is that over the last 4 decades, although survival has actually improved for a lot of solid tumors, survival has decreased for patients with endometrial cancer patients. As to the reason for this, one of the thoughts that might be related is it's one of the cancers that has the highest mortality disparities between Black and white female patients. And there's just been persistent underfunding for research that we're hoping to improve over time. So in addressing surveillance for endometrial cancer recurrence, what do we consider? So I'm going to allude back to the talks by my colleagues as to how we consider this, because really when we consider surveillance for cancer recurrence, the question is, well, what is the chance that the cancer could come back? Then the factors we consider are the stage of diagnosis, the extent of cancer, meaning at the time of surgery, the histologic type of cancer. So for patients who have higher grade cancers such as serous and clear cell, it's oftentimes more likely to come back at distant sites, more likely to come back in the abdomen and pelvis. Whereas with low grade endometrioid cancers, these are more often going to come back at the top of the vagina and pelvis. And increasingly, we're looking at the molecular classification of the tumor. Again, as Dr. Rodriguez mentioned, patients that have mutations with POL-E, these tumors found to actually have very, very low risk of the cancer coming back, whereas patients with P53 mutations have a much higher risk. And so there's definitely a push more for individualized surveillance that reflects that there's a very heterogeneous long-term risk of cancer recurrence that we need to really pay attention to when we're thinking about how to watch for any signs that the cancer is coming back. During that surveillance time, it's also important that we think about, well, is there a possibility that my cancer developed in the context of risk factors that might affect my risk for future illness? And what are the other health effects of my treatment to consider? So when talking about the modalities of cancer surveillance, again, this is specifically for endometrial cancer. It's actually been found that more than 80% of recurrences were detected just with a review of symptoms, meaning you come to the office and you talk with your doctor about how you're feeling and they ask questions, and then also physical exams. And actually what was found during COVID is that telehealth visits can also be effective as well as part of the surveillance. And unfortunately, there's all studies of multiple types of imaging, including CT scans, MRIs, have shown really low rates of detecting recurrence when a patient doesn't have any symptoms at all. A vaginal pap smear is also not helpful in detecting recurrent endometrial cancer. Certainly, it can be helpful when you have a history of precancer before your hysterectomy, but it's not something that will help detect endometrial cancer coming back in the area. Interestingly, there was a recent clinical trial that was done in Europe that looked at a strategy of aggressive surveillance, including more frequent visits and imaging compared to less aggressive surveillance. And unfortunately, it did not improve survival from endometrial cancer. There is potential utility of using serum biomarkers. Although CA-125 is historically used for ovarian cancer, both CA-125 as well as another biomarker, HE4, may be means by which to survey for recurrence. And a lot of attention has been garnered recently on the use of circulating tumor DNA. This is a blood test that looks at small fragments of tumor DNA in the serum of cancer patients. And I think it's important to date that although it's been found to be useful in other types of cancer, there is incredibly limited data in endometrial cancer. And we don't have any data on whether if you have this test, if it's positive, whether that means your cancer is there, or if it's negative, whether it means your cancer is not there. So at this point, it's really considered experimental. In terms of the frequency and duration of cancer surveillance, so again, I think this can be individualized. If you are a patient who has cancer and you have factors associated with a lower risk of recurrence, this may be a surveillance every 6 to 12 months. But if you have a higher risk cancer, you may be having visits every 3 to 4 months. As to how long that cancer surveillance should last, the majority of recurrences in patients with a high risk of recurrence occur in the first 3 to 4 years after completing treatment. So surveillance should be at least 5 years. But patients at low risk of recurrence may actually have persistent risk up to 10 years after cancer diagnosis and treatment. So it's really important to be vigilant of and report new symptoms. I included here a link to the Foundation for Women's Cancer. This is a patient advocacy group that partners with our National Physician Subspecialty Organization that provides a lot of resources on symptoms and potential survivorship plans for you. I'm going to move next to health promotion. So I'm going to talk first about, well, what drives the development of low-grade endometrial cancer? Now, this is not the only type of endometrial cancer. As Dr. Rodriguez and Banda alluded to, we now think of endometrial cancer as a lot of different types, but low-grade endometrioid is one of the more common types. What can drive the development? So one is, unfortunately, obesity. So in both females and males, when there's more fat in the body, that can increase the production of estrogen. That can then stimulate the lining of the endometrium to become precancerous or cancerous. Interestingly, diabetes or glucose intolerance can also drive the same transformation. So in looking at what are the impacts of that following a diagnosis of cancer, it's actually been found that many endometrial cancer patients, especially those with low-grade endometrial cancer, may be more likely to die of cardiovascular disease, such as, for example, of a heart attack than endometrial cancer because of those impacts of higher estrogen, because of that higher glucose level on the cardiovascular system. There's also a future risk of diabetes. And a review of endometrial cancer patients from Ohio who were undergoing survivorship, nearly 20% within 3 years after diagnosis were diagnosed with type 2 diabetes. For part of that reason, as well as the association of obesity with endometrial cancer, there's been a lot of attention paid. Well, how can we help our patients to lose weight with really the goal of just improving quality of life and overall health? And numerous clinical trials of interventions to promote weight loss have shown that participants have been able to sustain weight loss, increase physical activity, and improve quality of life. And it's important to note that a reduction in body weight of even 5% has been shown to decrease the chance of medical conditions related to obesity. Thankfully, although I don't have a bullet point about it, the use of GLP-1 inhibitors, such as Ozempic, is certainly something that can be now increasingly considered as part of this effort. And to date, although weight loss has not been associated with a reduced chance of cancer recurrence, it has been shown to improve other health aspects of health, which I think is important. So as part of health promotion moving forward after a diagnosis of a low-grade endometrioid cancer, certainly importance of monitoring for diabetes. That can be done with a fasting glucose or a glycated hemoglobin, both of which are blood tests. There has been shown to be potential benefit of metformin. Smoking cessation, should patients be smoking, is very important, as well as screening for cardiovascular disease and prevention of cardiovascular events. And this can be an evaluation for high cholesterol, for high blood pressure, and a discussion with a referral for a primary care doctor to discuss screening for cardiovascular disease. Weight loss surgery is also something that's been found to be certainly feasible, as well as it means certainly of improving cause of leading to weight loss, which then can improve other health parameters. I'm going to move next to survivorship, and I'm going to start with cancer prevention and screening. So, this is for patients who have had a diagnosis of cancer. Well, what do we do now in terms of adjusting life and trying to look for both signs of the cancer I was diagnosed with as well as other cancers? So lifestyle modifications, one is to limit alcohol consumption. Now, as many of you may know, the Surgeon General recently came out and recommended limited alcohol intake because of the association with alcohol intake with a cancer diagnosis in numerous cancer types. But actually, a recent study of specifically endometrial cancer patients in Canada showed that a post-diagnosis intake of alcohol of more than 2 drinks per week was associated with worse survival. It's important to note, however, that this was not because there was an increased risk of cancer recurrence. And what that means is that we can't say that that higher alcohol intake was causing an increased risk of cancer recurrence, but patients were having other health issues that was leading to reduced survival. Certainly, smoking cessation is also an important part of ensuring a reduced chance of a cancer diagnosis. For screening for other cancer types, as Dr. Rodriguez noted, Lynch syndrome is present in about 3% of endometrial cancer patients. And in the setting of Lynch syndrome, patients are known to have an increased risk of gastrointestinal, colon, and genitourinary cancers. And we actually have a cancer clinic at Fred Hutchinson for patients with such a diagnosis to talk about coordinating that surveillance care. Sporadic endometrial cancer, meaning patients who do not have Lynch syndrome but do have a diagnosis of endometrial cancer, should still be getting screened for other types of cancer, although their risk is not different. For colon cancer, that screening should start at the age of 45. And although it can include colonoscopy, which is considered to be the most accurate test, you can also have an annual fecal occult blood testing, a multi-target stool testing, which is called Cologuard, or a virtual colonoscopy. Breast cancer screening is recommended between the ages of 40 and 75, and that can include mammogram, digital mammography, or digital tomosynthesis. I'm going to move next to survivorship. There's been some really nice studies that have been done of endometrial cancer patients looking at the symptoms that occur during survivorship. This is essentially a word cloud of some of those symptoms that come up. And though I certainly am not the expert on this, many of you are, I'm going to try to cover those that patients have identified to be the most challenging. So I'm going to start with lymphedema. Now, as Dr. Gray mentioned, the use of sentinel lymph node biopsy is now considered standard of care, but the prevalence of lymphedema was at one time considered to be as high as 50% after surgery for endometrial cancer in which lymph nodes are removed. Thankfully, if sentinel lymph node biopsy is performed, that incidence can be as low as 4%. And that was really the main goal of introducing that surgery. But if that is present, early detection is really important. Some types of interventions can include manual lymphatic drainage therapy or fitting for compression garments. But it is important to note that if lymphedema is present, that can increase the risk of localized skin infections. And so awareness of any new redness or pain in an area affected by lymphedema is important. Menopause. So surgical staging for endometrial cancer includes the removal of the tubes and ovaries, but about a quarter of patients with endometrial cancer are actually premenopausal at diagnosis, and about 4% of endometrial cancers occur in patients 40 and under. Now, in patients who have an endometrial cancer that's confined to the uterus, there are some studies of national cancer databases that show that there's no adverse impact of preserving ovaries in such patients. Now, why would we preserve the ovaries when it's possible that cancer can spread there? Well, menopause can be associated with significant symptoms that affect quality of life, including vasomotor symptoms such as hot flashes, cognitive changes, vulvovaginal skin changes, discomfort with sex, and or reduced libido. I think one of our attendees asked a question about estrogen therapy. So this slide is about management of menopausal symptoms in endometrial cancer, but I'll talk at the end of this slide about the options for hormonal therapy and other gynecologic cancers. So for endometrial cancer patients, can you use systemic, meaning estrogen therapy that treats the whole body? There was a trial that showed that there was no significant risk of recurrence or death if you had a low risk endometrial cancer, meaning confined to the uterus. However, if there's an advanced stage endometrial cancer, it's thought that hormone therapy, unfortunately, may have potential risk of recurrence, and it's not recommended. It's also important to note that when you use systemic estrogen therapy, there's increased risks if you have high blood pressure or a smoker. Now, what about local estrogen therapy, vaginal estrogen? As Dr. Gross mentioned at her talk, when someone uses vaginal estrogen, the amount that your estrogen level in your whole body goes up is extremely low. So local estrogen therapy is very, very appropriate even after a diagnosis of endometrial cancer or after potential treatment to help some symptoms from menopause. There are certainly non-hormonal options for managing other menopausal symptoms, and some of those include a class of drugs called SNRIs, or serotonin norepinephrine reuptake inhibitors. One of these is called venlafaxine. There are also another class called SSRIs, selective serotonin reuptake inhibitors, such as paroxetine. Other drugs include gabapentin, and the newest drug is fezolinetant. And all of these drugs are non-hormonal options for managing symptoms like hot flashes and night sweats. For pelvic health, there's very often altered function of the pelvic organs, not just the vagina, but also the bladder or the bowels. And this can be due to surgery as well as subsequent therapies. And in fact, 10% of patients who underwent radiation for endometrial cancer in a retrospective or looking behind assessment had bowel symptoms that impacted their lifestyle. And there's a high prevalence of urinary incontinence, up to rates of 80% after treatment for endometrial cancer. Some modalities that can improve this: pelvic floor physical therapy, a specialized form of physical therapy that improves core and pelvic muscle strength, can improve these symptoms. Evaluation by subspecialists in urogynecology can help if you have urinary or fecal incontinence. Antidiarrheals for chronic diarrhea can be helpful. And then for patients who may have vaginal atrophy and or scarring, dilators as well as vaginal moisturizers can be helpful. And there was a benefit of a hyaluronic acid-based gel that was shown in a trial of endometrial cancer survivors. I listed 2 with icons down there as potential examples, although there are certainly others on the market. For sexual health, I think, female sexual health, and not to, speak ill of my male counterparts, but it's just very, very complex. So this was a diagram that was done recently by Dr. Bassett, who's a nationally known expert in female sexual health. And the female sexual cycle is complex. But as a result, there are at least 3 domains of sexual dysfunction. This can include sexual interest or arousal disorder, difficulty achieving or reduced intensity of orgasm, or discomfort or pain with vaginal penetration. And so how can we intervene on these? So for sexual interest and arousal disorder, psychotherapy can certainly be helpful. Flibanserin is a prescription that may aid with libido. Testosterone is a tricky one because there are a lot of risks of testosterone therapy systemically. It's not FDA approved. And there is concern that it may increase the risk of cancer. There have been reports of patients taking testosterone therapy that have developed endometrial cancer. And so it's really tricky to know the risks and benefits of it. So I think it's important that if you're considering this as an intervention for a libido disorder, to talk with your oncologist about it. For patients who have difficulty achieving or reduced intensity of orgasm, cognitive behavioral therapy, directed masturbation can be helpful. And then also, should you be on an SSRI class of antidepressant, to change to a different one, because SSRIs such as Paxil are associated with reduced sexual side effects. For patients who have discomfort or pain with vaginal penetration, I listed numerous options there, but again, it includes daily vaginal moisturizers, vaginal estrogen. Topical numbing medication can aid with dilator use if you've had radiation. Lubricants for intercourse, pelvic floor physical therapy, as I noted, or a newer drug called ospemifene, which also has been found to be helpful with vaginal atrophy. And I listed up there in the top right corner, AASECT. This is the American Association of Sexuality Educators, Counselors, and Therapists. Certainly, should you and or your partner be interested in seeing a sex therapist, this is a great resource. I'll cover next mood disruption. So I think it's important to note that depression and anxiety in cancer survivors is incredibly common. More than 85% of gynecologic cancer survivors report some level of psychological distress. This can be in part due to fear of recurrence. And unfortunately, other conditions such as pain or fatigue can cause or worsen these depressive symptoms. So what are some potential interventions? Mindfulness exercises, although that covers a large amount of interventions, but that has certainly been found to be helpful. Cognitive behavioral therapy, which I just like to think of as talk therapy, physical exercise, or the use of antidepressants or anxiolytics. For other treatment-related health effects, many patients who undergo chemotherapy for their cancers may end up with neuropathy. This can be a numbness, a tingling, and or a pain of the hands and feet. Some interventions that have been found to be helpful include acupuncture, duloxetine, the trade name is Cymbalta, gabapentin, or compounded topical therapies. There have been some therapies that contain drugs called ketamine and amitriptyline that have been found to be helpful. Cognitive dysfunction, otherwise known as chemo brain, is a real element. It's a very complex dysfunction that it's not necessarily just due to chemo on its own, but likely multifactorial. But things like memory aids, stress reduction techniques, as well as physical exercise has been found to be helpful at combating this. And fatigue can be really a long-term problem after cancer therapy. So should this happen, it's important to be evaluated for other contributors to fatigue, such as anemia, thyroid disorders, renal dysfunction, or a mood disorder, and physical activity has also been found to be helpful. So just as I wrap up, I wanted to list, this is by no means an exhaustive list, but this is some really excellent resources for patients with endometrial cancer. So Foundations for Women's Cancer, again, this is a patient advocacy group for all patients with gynecologic cancer, not just endometrial. ICANA is a really fantastic network that was created by Dr. Gross's mentor, specifically for African-American women with endometrial cancer. To the left, we have Share Cancer Support. This is a website for patients with endometrial cancer, or my endometrial cancer team. And I noted earlier in the talk, are there any other educational options that exist? So this is a list of FWC, or Foundation for Women's Cancer, cancer educator courses. These were developed in collaboration with our colleagues in gynecologic cancer. This is a great series of both of write-ups as well as webinars to watch. And these are not just for patients with endometrial cancer, but really any patient with gynecologic cancer. And with that, I will say thank you and come back to answer some questions.
That was excellent, Dr. Urban. Really nice overview. And I think really gave great resources as well at the end. I think you answered some of the questions that came up. One specific one that a patient asked about was about the safety or risks in using vaginal estrogen after a diagnosis of stage 3 endometrioid cancer.
So that's a great question. And I think, as we talked about a little bit earlier, for patients who have a uterus in place is a different group. Once your uterus has been removed and you've been found to have endometrial cancer, at least to date, vaginal estrogen, although, it may have a theoretical risk when the uterus is in place, once the uterus is gone, it's considered really to be safe. And I would think would be a very, very reasonable intervention to use for either discomfort with intercourse, for symptoms related to atrophy, or for changes in the vulva and the vagina that are causing any other symptoms. So my personal preference and my practice, I prescribe this quite frequently. I think if you have a patient who has any other kind of hormone-dependent cancer, it's important to collaborate with their oncologist or talk with your oncologist about whether there's any other risks we need to think about. But again, the body absorption of vaginal estrogen such that you get more body estrogen is very, very low, if not anything at all.
I mean, and I would just say to just be, so we don't know that use of vaginal estrogen is safe in more advanced cancers. I would just clarify
that is a great point.
The data suggest in early stage 1 or 2 that it is safe, but we actually just don't know. So I think it does require kind of a careful conversation with your oncologist, because it may increase local risk. We don't know it in more advanced cancers, just to be clear. And then I think there was a question, maybe to clarify about, can you elaborate on why weight loss is not associated with decreased risk of recurrence when obesity is a known associated risk for endometrial cancer?
So I think that's a great question. Some of what has been hypothesized is that a lot of those studies don't necessarily are looking at patients with all stages of disease. And since patients who have low-grade endometrioid cancer are the most often ones to be diagnosed at the time of the cancer just being in the uterus, removal of the uterus, that is essentially kind of removing the organ that got affected by that high estrogen due to obesity. And so there's a much less likelihood of cancer cells in the rest of the body that are endometrial cancer cells that could then be impacted by that high estrogen. However, there's still the rest of the body that can still have impacted by the ramifications of obesity, and that's why that's seen. I think that, if we were to try to look at a larger population, a group of patients who had low-grade endometrioid cancer with advanced stage, it's hard to know whether it would be the same finding, but at least so far, it seems to be the case.
And I would just add to that, I think, weight loss intervention is very important kind of post a diagnosis also, because we know that for a lot of patients, if their cancer is diagnosed at early stage, the risk of recurrence of the cancer is very low, and so their survivorship rates are very high. However, we do know that, as Dr. Urban had said, that the risks of having other medical, conditions, heart disease, stroke, things like that, can be impacted by weight loss. And so it is very, very important. And as Dr. Urban had alluded to, I think we're going to learn a little bit more in the next, few months to years about incorporation of the GLP-1 inhibitors, and we'll hopefully be able to work more with the primary care folks about incorporating that in survivorship.
I also saw a question from one of our attendees. Is in remission permanent unless cancer returns? And is this a label we use forever? So that's a great question. And I think, often it's considered for all cancers. So once you get to a point about 5 years after your diagnosis, and we haven't seen any sign that the cancer's come back, that the cancer is cured. Now, that is a little bit of an arbitrary cutoff, that use of 5 years. But I think it's important to note that if you've gone a long period of time without your cancer coming back, and that you can discuss with your oncologist whether we can call this cured. I do think that it's very individual. And it depends on the type of cancer, as well as in some ways the risk that it could come back.
Yeah, those are important questions. It can be really challenging, the terminology, and I think, many oncologists will use the term remission when there's no detectable cancer by exam, by blood work, if that's how it's being followed, or by imaging, if that's appropriate. And there are some cancers, and even an endometrial cancer, that do have high rates of recurrences or relapses. And so using that word remission, because sometimes even if you have a relapse, you can be put back in a remission or cancer-free period. So, but appreciate the questions, because I know it can be confusing.
I see another question. Are studies being done on the ctDNA? So the short answer there is yes. There's kind of ongoing research being done, but I think that I think what's tricky is that there can be studies done to look at ctDNA and then correlate it with what's called kind of outcome in cancer patients, but to then take that a step forward and then say, to change our treatment recommendations based on ctDNA is kind of the next step forward. And we haven't even gotten to that first step quite yet. So the short answer is yes, but I do think that it's some time until we'll be doing that. And I think another question is, what are our thoughts on the use of Signatera testing? So to the person who asked this question, Signatera testing is essentially a form of ctDNA testing. I at this point don't recommend it in clinical practice. I think it's just not been found to be reliable enough. And so I personally don't use it. I don't know, Dr. Banda, I don't know if you have any thoughts on it at all. Don't use it either. But I'm interested in hearing about research that I know is ongoing.
No, but just to clarify, there are other ctDNA tests that we use, which are like, meaning there are tests that we talked about, the molecular profiling. Sometimes you cannot get tissue for molecular profiling. So you look for ctDNA in the blood to look for those molecular profiles. And those are a valid test. And if you cannot get a biopsy, or it's just not possible, it's been too long since the last surgery, we try and do ctDNA tests. That's different. Yeah, that's like, some of them are Guardant or Foundation or Tempus. Everyone has some sort of ctDNA test for molecular profiling. Signatera is an entirely different test where you're looking for, is there cancer still, like invisible cancer still there in someone when there's no visible cancer? That's entirely different from the other tests.
And that is used in some cancer types. And so if you know people who have a different type of cancer, there are other cancer types where it's more common to use it. I think one question that has to be answered is even if we can pick up a recurrence at a very, very early, basically microscopic point where you can't see anything on a CT scan or exam, does that help people? Because in ovarian cancer, we do follow markers like CA-125, but we have studies to show that even when we pick up basically CA-125 elevations or tumor marker elevations with nothing objective or on CT to correlate it to, it means people are being on treatment for more time, but doesn't necessarily improve how they do long term. And so I think from a scientist standpoint, ctDNA is fascinating, and there are like potentially a lot of things that we could do with it. But in terms of like how useful it is from a clinical standpoint, I think we're still figuring that out.
And I think just we haven't answered this question. CA-125 is used to monitor endometrial cancer after completing treatment, but isn't specific or sensitive. And so are there any other markers and or radiographic studies we recommend after treatment for monitoring? So, unfortunately, in the setting of no symptoms at all, routine imaging, whether it be CT, MRI, even PET, has not been found to be helpful. And in fact, as I noted, the majority of patients whose endometrial cancer comes back, it actually gets picked up because they have new symptoms and or have new findings on physical exam. Although certainly CA-125 and or HE4 are serum blood tests that can be used both at diagnosis and can be used to follow. And so those can be used after treatment as well. Okay. Well, I want to thank everyone for attending today. For those of you who are attending and know someone who registered, okay, I'm going to answer one more question. I'm confused about Guardant 360 and Signatera. Been doing both tests and thought they were FDA approved. They are FDA approved in other cancer types. I don't, Dr. Banda, if you want to elucidate a little bit more.
Yeah, FDA approval just means that FDA has said you can use this test or test or drug or food for something. Now, there can be a multiple different uses. So, for example, Guardant 360, the way it exists today, although they have other tests coming up, is you're looking, like we said, patient has gone through chemo and some immunotherapy, and you're wondering what other treatment options there are. But you can't get a biopsy. And the surgery was done 5 years ago. You're like, things have changed. So let's get a liquid biopsy. And that's what Guardant 360 is. And then you get the liquid biopsy and say, are there some mutations? Are there mismatch repair? And so can we give them immunotherapy? Can we give them some drug A? Can we put them on a clinical trial? That's what the most common tests are. So, and that's going to be Guardant, Tempus, Foundation, even Myriad have some of these tests. There are a lot of different tests. Signatera is asking, usually the test is, well, we treated someone for early stage uterine cancer, stage somewhere 1 to 3, they got their surgery, they got their chemo or radiation, whatever it is. What you're asking is, can you, is the cancer going to come back or is it there invisibly? That's what Signatera does. So these are very different tests with very different indications and very different results with different meanings. So really it is something that, you have to discuss very carefully with your oncologist.
And just to follow up on that, because people say, well, why wouldn't you get a test? Wouldn't it be important to know? There both can be harm in the sense that if the test is read as negative and there's reassurance that there isn't a recurrence when there really is, and we don't know that, or what is happening probably more commonly is it comes back as positive, but we don't actually know that that is representing a true recurrence. And then would you intervene and do something like chemotherapy or or something that's very aggressive when we don't know yet if that is going to be helpful. I hope that kind of clarifies that a little. I mean, we think we will incorporate some of these as we learn more about that, but we also need to be careful we're not causing more harm by some of these tests.
And just to add to a little bit, there are these kind of tests have been done in many cancers, and many different cancers. They say if you have the ctDNA positive, that means somewhere it's invisibly there. That means there's a risk that it might come back in the future, and that means those patients are not going to do well. But in none of those cancers, we've shown that just because you have the ctDNA and you start on some treatment, it actually prevents the cancer from coming back or it makes them live longer. So it's not ethical to say, hey, I have bad news for you. There's a good chance the cancer is going to come back, but there's nothing I can do about it. So good, get on with life. That's not a position we want to put anybody in. If there's nothing you can do about it, should you actually give them, is that information valid and ethical?
Well, I do want to wrap it up. Really want to thank everyone for participating. I want to thank all of our panelists, really thoughtful, incredible presentations. The slides will be available and we'll make sure of that. Please fill out your evaluation forms. It really helps us to know kind of what was helpful, what wasn't. We really enjoy feedback. These patient-directed seminars are fantastic for us and help us learn as well too, what's important to you and all of that. So please do that. And really thank you again for your attention this morning. All right.
Thank you so much, everyone.
All right. Bye-bye. Take care.
Thank you all.